Okay, welcome. For the sharp-eyed, you'll notice I'm not John.
Yes.
John is unfortunately, and as you know, very rarely off, but for personal reasons, he's not going to be able to chair the meeting today. And so you've got me, little known vice chair, rarely used, but today I'm going to be in charge of running the meeting. We've got a pretty full agenda, so we're going to try, as John does, to keep to time as much as possible. There will be some apologies from the exec team who have to step out for some critical meetings this morning, so there will be a little bit of reordering, particularly on the IPR, which will move to 12:15 most likely, and everything else after the IPR will be brought forward just to time with a meeting that Kate needs to go to. And we also have, I know, apologies from Susan, who is sadly down with an illness as well. So we have Susan's deputy. I don't know if everyone knows, and I don't know your name either. Leighton, yeah. Leighton, who's going to be stepping in to cover that. Okay, great. We'll get started with the agenda. Formal apologies, in addition to Susan, from Kelvin, Nigel Atchison, Emma Ridgewell Howard, and Ali Bullman. And Rachel will be deputising for Ali, with Nick deputising for Emma. Have we got, I know Rachel, you're here, but have we got Nick perhaps online? Nick Rogers? Okay.
Yeah, there we
Great. Hi, Nick. Welcome. Declarations of interest, just noting the contents of the register. Questions from the members of the public? Yeah.
Declarations of interest, which is that my husband is a trustee and treasurer of CCF, and CCF is mentioned in Emma's partner report. So I just wanted to restate that, please.
Okay, that's noted. Thank you, Debbie. We have one question from the public, asked by Nigel Mawson. The chair's report on this agenda refers to a 30% reduction in overall ICB running costs. What is the rationale for this? What functions are now deemed unnecessary, which are to be retained, and which are being passed on to others, such as providers? In particular, but not exclusively, I'm interested in the ICB's future ability to support proper public engagement through the Cornwall Isles of Scilly system. Patrick, yeah.
I've got the answer to that question. So all ICBs nationally were set a requirement to reduce running costs by the NHSE in March 2023, comprising a reduction of 20% for 24-25 and a further 10% for 25-26 financial year. In response, the Cornwall Isles of Scilly ICB has redesigned its organisation to meet both the cost reduction requirements and ensure that the organisation is fit for purpose, able to lead the delivery of the board's strategic priorities as set out in the joint forward plan and the integrated care strategy. So that redesign has seen the development of a new functional model for the ICB with a focus on the development of clinical leadership, strategic commissioning and system leadership capabilities. The first phase in 2023 saw the creation of a new leadership team for the organisation. The second phase is currently underway and is reviewing commissioning and support teams. The detail of those proposed changes is subject to consultation with staff currently. They meet the required cost reductions, and I think the important point is they do not affect the ICB's ability to deliver its statutory duties for public engagement. That answer can be provided in writing as well.
Great. Okay. Thank you, Patrick. Next on the agenda was approval of minutes from the 8th of February, as well as actions, matters arising. Are we happy to approve the minutes? Yeah. Okay, I'm going to take those as approved. The actions arising, I don't have anything listed on the agenda for that one. Okay. And then health and care vignettes. Thanks, Lucy.
So this month's films showcase an array of different support and initiatives that are on offer across Cornwall City, including the Seafit initiative, set up as a partnership collaboration led by Fishermen's Mission and the Seafarers Hospital. But we have a lot of partners that are in this room today, and it's really making a difference locally. And we have attended a number of Seafit events as part of our wider engagement activity as well. And also the community larder, which provide a vital service. The community larder features is Perranporth, but these are popping up all over the place and providing a vital service over the winter. We hear from Mr. and Mrs. Taylor about her challenges navigating the system as she sought to access care after her husband's health declined. And we also hear from a fantastic project at RCHT, Royal Cornwall Hospital, which is helping people with learning disabilities and autism if they come into the hospital, and new signage and booklets there. And then, of course, the primary care hubs, which are now up and running across 8 locations and are providing, along with wider GP access appointments, nearly 20,000 extra appointments over the winter period. Thank you.
Thank you, Lucy. Opening up to the floor for comments, questions. Neil.
Thank you, Chair. I just wanted to, there was a phrase in the CFIT video that absolutely leapt out at me, and it was, "We go where they are." And I think for groups of people who we're working with, that is the way forward. And I know that that is the approach that some of the neighbourhood teams, particularly in terms of developing preventative approaches around certain aspects of care, are going to do, because lived experience is something that you learn from, and actually going out and going to where people are is the way to get the people who we're not engaged with and who we're not actually delivering care for now. So I was very impressed with that. And on the Makaton, I thought that was excellent, and I just wanted to congratulate RCHT on that work, which demonstrated working with people with lived experience and really opened my eyes, actually. I don't think I've seen enough of those signs and knew enough about it, actually. Thank you.
Thanks, Neil. Emma?
As you might expect, I would just like to reflect on the number of stories that involve voluntary community and social enterprise sector, and I think they demonstrate again the massive range of work and support that organisations and just groups of volunteers actually in relation to things like the community larder are doing up and down the county.
Great. Nick?
Yeah, thank you, Chair. So, Sandra, I think my reflection across a lot of these and thinking about my committee about equity and access, I think what a lot of these things show is actually these are real system approaches in a lot of these stories, and meeting need where it is from the primary care hubs. You know, you've got stories across all parts of our system, and I think, as Neil says, people accessing the care where they need it. So I just a great. A theme of great access and trying to meet some of that need. I think the system, all parts of the system, need to be applauded for that. So, thank you.
Yeah.
Thanks, Sanj. Yeah, great vignettes as usual. When I was looking at the primary care hub one, it did bring me in mind of, you know, how much sort of responsibility do we have versus national on how people are, I suppose, educated at where to go to get their sort of treatment that might not be necessary. And, you know, I know it's so difficult to get people either to people who should need treatment who don't go, and people who, you know, perhaps could be turned to a different location to go to the other location. And I know, you know, from my own experience, I think I'd be quite well educated, but it wasn't until coming here that I found that, you know, something I'd been to the GP for, I could have actually just gone to the pharmacist for fairly recently. So, you know, what role do we have, and how do we get better, I suppose, at targeting that message to people?
Yeah, okay.
So I think that's a really great point, Martin, because as we go into next year, helping our whole population know where they can go to get timely access to care or advice, rather than using maybe traditional places that they've gone in the past. So I think, Lucy, that's maybe something we need to pick up around how our communications supports the engagement of our population.
I think the Pharmacy First initiative is really offering real opportunity this year. And Drew spoke earlier about the opportunity there this Easter to try out and push that messaging. And it continues Where is Best campaign, which is really successful over the winter. And that's what we're planning to do this summer as well.
Sorry, I should say I'm Jodie Wilson, deputising for Debbie Gilbert from Healthwatch Cornwall. I was just going to reflect a bit more further on that point, I think, from Martin and Sheila's story, because at the end it talks about Cornwall Carer Service, but it's clear that actually they didn't access that service to get the support. So there's a missing link there, and perhaps it's something that we talk about a lot, as people identifying themselves as carers in the first place and knowing that the carer service would have been appropriate for her to access and them to support them. So I guess it is about that communication, about there is support there and through the community hubs, etc., but it's not reaching some people. So what can we do to actually highlight to people in her situation? And sadly at Healthwatch, we do get a lot of people coming to us and saying we don't know where to turn. We're able to signpost to the amazing organisations that there are, but there are a lot of people that just wouldn't know how to navigate the system. It is really complicated. I'm having to do it myself and I find it a struggle to navigate. So obviously people in this situation do as well. And I think particularly if people are seen to be self-funding, I think they really take themselves out of approaching maybe the council for support that they could offer.
I think it's National Carers Week this week, and I think that's a really important point. I met with colleagues from our patient experience teams yesterday, and they spoke about a fantastic initiative at the Royal Cornwall Hospital Carers Corner, which has been expanded to West Cornwall Hospital and also across the CFT Foundation as well. So that is a real sort of pop-up carers initiative that's in places where people are going, which they want to expand. So we will be bringing a story about that back in, and I think carers communications is really something I'm really keen that we do more of.
I think it's spouses don't always see themselves as carers. That's commonly known, isn't it? So it's about maybe changing some of the language to recognise that they are caring, even if it's they feel it's their duty because they're married or cohabiting with each other.
Great. Thank you. Thanks everyone for your input. Yeah, I think some great vignettes this month, particularly "We Go Where They Are" is a great slogan for place more generally that we can co-opt as well. I do think there's a pattern around people going out of habit to the same places, whether it's A&E versus minor injuries, because they're not aware, but also I think lack of knowledge sometimes leads people down one road rather than the appropriate road. So there's a lot to take away from this and to learn. So thank you all for commenting, and also for Lucy and the team for putting the health and care vignettes together. Okay, we'll move on to the ICB Chairs update. So on behalf of John, there's just a few things I want to say before we'll hand over to Kate for the Chief Exec's update. We should be really proud as a system that we're looking at a possible third year of a balanced budget, and really to commend how we've come together to do this across the system with providers to be in a very strong position that Simon will report on. So thank you all for the hard work on that, as well as on the system getting through and still getting through a very tough winter to get through some significant challenges, including a critical incident in January. And I know a lot of hard work went on, and John wanted to pass on his thanks to everyone in the system for that. We also have reported, and there was a question that's been answered from Nigel around the reduced ICB run costs of 30% that I wanted to flag and John wanted to mention. Kate and John also met with Matthew Harris from Imperial regarding the community model, sometimes referred to as coming from Brazil, and the success we've had in hiring community health workers, wellbeing workers in both the West and Central, 22 in the West and 10 in Central, and working towards that in North and East as well, which is great to be able to report as well. One significant update that I wanted to flesh out a little bit that's in John's update is around joint quality committees, and there's been a lot of work with providers and ICB and John around standing this up from April, and there are further details to work out in terms of format and details of that nature, but the hope is that these will start in April and run every other month, and it's an opportunity, I think, across the system to think about quality of care. And I know we've had less success in other areas, and the hope is that quality will serve as a model for joint committees in the next financial year. as a result of which there may be changes to the format of the ICB, which we will share with people in the coming month, and at the same time stand up that joint quality committee. But I know these things don't just come together. There's been a lot of discussion, cooperation, collaboration behind the scenes to get to this point. So thank you everyone who's been involved on behalf of John, and really pleasing to see this get stood up. Any questions or comments on the chair's update? Yes, Margaret, hi.
Hi, Sanj, thank you. This is just something that John and I had discussed prior to this meeting, and he asked me to raise it today, which is we don't spend a lot of time here actually talking about the services that we are delivering. And so I'm suggesting that we do a showcase at each meeting where we get the people that are delivering services, particularly those services that we deliver, either RCHT CFT partnership, RCHT CFT council partnerships, VCSE partnerships. So not just a standalone CFT or RCHT or VCSE service, but one where we're showing our partnership working.
Yeah.
And I can give several examples, but one I'd like to shout out, Andy Sand, is the ECHO project in up in this guard. Sorry, I was going to say Launson. I knew it wasn't Launson. Because I think that's a classic case of where we're working CFT, RCHT, ICA, VCSEs involved, and it's lovely. And it's also the neuro services or something that sort of just get over there.
Yeah.
So I would like to put that forward, and I'm sure we could come up with a work plan for others, because there are lots and lots of them.
Yeah, and you mean that for the ICB rather than for the joint quality
No, I mean,
ICB? Yeah.
I think it's something that we all need to see. It's a little bit more immediate than the excellent vignettes we have on patient care.
Yeah.
But it's actually hearing from the people who deliver our services, and I think it would be useful.
Right.
And John agrees, by the way.
So I think that's a great idea, because one of the I was reading about a new fracture liaison service that has been developed in partnership with St Agnes Practice. But I am also aware that Rachel's doing some work on falls prevention. We've got the falls car that helps people once they've fallen over, and we've got the women's hub that will be starting to focus on menopause, brackets, often causes of fragility fractures for women when they're older if we don't treat menopause well. So there is something about how we pull together the segment of work that we're doing, and as a board, realising that this integration thing is happening across the whole of the county, and that we need to celebrate that a bit so that we know what's happening.
Yeah. Debbie.
Just to build really on Margaret and Kate, so I think it would be really helpful if we could actually agree some of those principles about showcasing partnership working, but also given our role to reduce health inequalities and improve inclusion, I think it would be really helpful for those two elements to flow through as well, so that we can actually start to get into that space of what we're doing in these different partnership services to achieve those aims in our clinical strategy.
Thanks, Debbie. Mary?
Just to say that I know it's only a pilot at the moment, but the X-ray car is proving incredibly popular with care homes. Absolutely fantastic results.
So we what did we do? We exhibited the X-ray car to two of our local councillors that were absolutely amazed that how well it's working, and also it's now working across Cornwall. It's not just in the west. Yeah, so no, it's fab.
Neil?
I think Steve was...
Oh, sorry, Steve. And
Do you, Neil?
Just say, I mean, as chair of the Integrated Care Area Committee, I would really welcome the showcasing, because so often we know that things are happening at place, and that demonstrates the importance, not just at board level, of the way we move forward now with our new way of working in the ICB, with the place directors aligned with clinical reference groups, aligned with relationship managers, so that as we develop a new way of working, we're actually all aware of what's going on, because so often we're not, and there's lots happening and we don't know it is, and people are developing strands of work and not being aware of the good work that's going on somewhere that could be rolled out elsewhere. And as chair of the quality committee for the ICB, just to say I've had very constructive discussion with the chairs, Miriam and Isabel, of CFT and RCHT in terms of how we might begin a way forward that's not just based on a framework or governance, it's based on building relationships and looking at how we can work better together, which I really welcome and really valued their time and input.
Thanks, Neil. Steve?
Yeah, thank you. Two things. One, just to follow on from Margaret's comment, I strongly support that. I also think one of the challenges is there's so much fantastic things underway across the whole system that how we combine not just the showcases and the deep dives, but communicate all of that work that Neil's touched on as well is a challenge for us just in terms of how we engage with that. And I was thinking one of the kind of very recent examples for me is Royal Cornwall Hospital's this week were identified as the best in the country for patient-initiated follow-ups. So that's a transformation in terms of how we empower patients to take charge of their journey of care. And there would be so many of those kind of examples underway right now that there's a challenge, I think, Lucy, in terms of how we communicate and share that. So that was my first comment. The second one is with regard to the System Quality Committee, Sanj. I think that's a positive step forward for us, so certainly I support that. I think it will be important that we set out clearly what is in the remit of the System Quality Committee. There is a significant quality responsibility within the ICB, there's a significant quality responsibility within the other statutory bodies. So I think a part of our ability to be successful in the System Quality Committee is to be absolutely clear about what's in that remit and what is in the remit of the other mechanisms that we have. So it would be helpful, I think, to see that detail and probably it's just brought back to the ICB board so we can have that that kind of joint understanding.
Agreed that the terms of reference needs to be careful not to create overlap. It's a similar discussion we had last year around other joint committees and avoiding duplication of effort. So I definitely endorse that view, Steve. So I've got Nick and then to you, Margaret.
Yeah, so thank you. I'd support that. I think there's a couple of things I'd say is, showcasing at a wider level is fantastic. So, but don't, in my other worlds, you can think of, Cornwall being the first place where you can get a cancer referral directly into secondary care from pharmacies in the West, which is unique and the first to go in England. But I do think there's something about how you try, if there's people that are making both those transitions between different parts, but also even with simple things like Pharmacy First, if there's some ways that you can showcase great communication between general practice partners and pharmacies, that people haven't sorted those things out properly everywhere. So there's lovely, the big, the shiny, but actually the day-to-day that's working really well is really important because that'll have huge operational value. I think as well within my committee around equity, to comment on that is where does that sit and how do we feed into that as well as taking board time. The other thing I would say as well is, having sat briefly on a regional committee yesterday between Devon and Cornwall in one of my other worlds, is that how do we also showcase the great that we're doing outside of this room? What impact can you have regionally, nationally, those sorts of things? What can we learn regionally and nationally? So I think there's a bigger question about showcasing within the room, but there's also a thing about actually we do amazing things here. We're not perfect and we're not brilliant at everything, but we do some amazing, and how do we talk about that? I just think we should remember that when we're all in a strained and challenged environment.
Thanks Nick. Chair. Thank you. Margaret?
That's my point. There's lots that we can showcase, but could we maybe focus on the things that never get talked about? So false cars are great, X-ray is great, but we spend a lot of time on urgent and emergency care, and so there's a lot of services that are the backbone for people with long-term conditions. There's good partnership working elsewhere. So rather than using the usual suspects, let's be creative about looking at those pockets of excellence that actually we never hear about because they're just getting on with it. So that would be my plea.
And I think it'd be great if we could align it so that there's some coherence to it. So the Working Well initiative, I'm old enough to be in the Department of Health when improving access to psychological therapies came out of Dame Carol Black's work around getting people with long-term mental health conditions back to work. So then talking therapies was invented, but also the Work Well initiative is that about chronic pain. It's about people with long-term conditions. So if we could take something that's got like a policy wrapper to it and then talk about how we are looking at that locally, because Debbie and I have been talking about talking therapies. There are lots of different ways we could roll talking therapies out across Cornwall and the Isles of Scilly. They don't all have to be through Cornwall Partnership Trust, but there needs to be an overarching quality label that says wherever you get it, it's going to be to the same standard. So I think they're really good points. And maybe, Lucy, we should take that away and get a few candidates for the first insight sessions.
Rachel.
Just a quick point. I really welcome this, but at the same time, I guess, and the chair and the chief exec's report are really helpful in this, is sometimes signposting those discussions that have taken place in other forums and partnerships and boards. So where there may be the Health and Wellbeing Board for certain examples, or the Integrated Care Partnership, where a lot of the interface between the council and NHS is discussed. So I think it's also having regard to things that have been brought up there, which is often, I say, highlighted, so that the ICB board itself isn't going to be able to have the time for covering all of those. But I really welcome that opportunity to showcase some of the really good work that we have progressed.
Great, thank you. Some great ideas there to take away. I think there's a theme around joint initiatives and working together as a system that Margaret raised. I think Steve's point around where we are outliers of success, I think in particular, was interesting. I think Nick's points around regional and national learning that we're bringing in or involved in as well as Rachel, your point around signposting things that are happening beyond the remit of this group but are part of the system. So we'll need to take that away and think about how we use the precious time in the ICB to give some focused updates beyond the health and care vignettes as well. So thank you all for your input there. Great. I'm going to move on. Chief Exec's update, over to you, Kate.
Thank you, Sanj. I missed our last board, but since the January board, we've had the Hearing Families screening of the video that was produced around Ben and Darren and their mothers, Hazel and Jane's, continued pursuit of having families' voices heard as part of care delivery for the people that they love. And one of the things that came out of that event that had around 40 or 50 people there was that engaging families or involving families is structural and individual. So it's not just what we do, it's how we do it. So we were all asked to make pledges at that meeting. And one of the pledges that I've made is that when we get into the phase 3 of our restructuring, when we're looking at how long-term packages of care are put in place for vulnerable people in Cornwall and the Isles of Scilly, and how our continuing healthcare services assess and plan care, that we involve our carers in how those services are put together, so that we can look at how, because I hadn't thought about it, which is really awful really, but when your child is in the care of a third party and you've got concerns around how that care is delivered, how do you have advocacy? So how do you raise questions when you're worried that the provider might stop you seeing your loved one? So I think there's just something for us around how we plan what we do next, so that we can show that we are structurally responding to very, very sad cases. I went to the Admiral Nurses Supporting Ahead programme down in Marazine. It was amazing. So the Admiral Nurses that are employed via CFT and RCHT, working with people with dementia and their families, helping them to access the services that they need. And there was a workshop of lots of different resources available to people and their families that I'm going to keep in contact with the Admiral Nurses, so that as we're developing services and our dementia strategy rolls out, that we're making sure that they're at the middle of it. The debrief for the critical incident is next week. It's a long time after the critical incident ended, and at the moment we are in a really difficult position for emergency care access in Cornwall and the Isles of Scilly, down to norovirus, COVID and flu. So RCHT and UHP have got a number of beds that are closed on the back of people with infectious conditions in the hospitals. So still in the midst of winter, still everybody working together to make sure that we can provide the access that we'd like. Leighton will cover the performance in the integrated performance report, but I would just like to thank RCHT and CFT and General Practice for working together to make sure that our 4-hour standard in ED and in the minor injury units is held at around 76%. So 76% of people are seen within 4 hours. And that work is, although we're under massive pressure, people are being moved through our services as quickly as possible. I won't cover planning because it's on the agenda for later, but I would like to touch on West Cornwall Hospital. So I know that we have members of the West Cornwall Hospital community with us today online. And just to be really clear that the contractual arrangement is for 24-hour services at West Cornwall Hospital. And I just wondered whether Steve Williamson, in terms of where we are around bringing those services back online, whether you'd just like to make a couple of comments.
Yeah, very happy to do that, Kate. Thank you. So West Cornwall Hospital currently operates 7 days a week until midnight in its urgent treatment centre capacity. I think, as all board members will be aware, the key challenge for RCHT and West Cornwall Hospital is ensuring safe medical staffing levels to be able to extend that opening hours further. So currently those arrangements 7 days a week until midnight continue. We're not in a position as RCHT to be able to extend those opening hours further at this point. That is under further review to consider further options that would allow us to return to the 24/7. We'll be reviewing that within RCHT, and we've made a commitment following last month's ICB board meeting to provide a 3-monthly update to the ICB board. That's not to say action wouldn't be taken in between those 3-month times. We're continuing to review all options that would enable a safe and sustainable return to 24/7.
And it's probably worth saying at that point, we're using our learning from this winter's initiatives to look at how we get 24/7 services available around the county. So that will feed into those discussions. I just wanted to touch on the NHS staff survey for the Integrated Care Board. Our staff survey is sadly very poor. We are in the middle of restructuring. People are feeling the difficulty around that. So we are hopefully going to be able to agree that our phase 2 restructure is finished. We're responding to consultation at the moment, and our people will find that we're changing some of the consultation options in response to the feedback that we've heard, and then we will go into filling those posts. And we've got a third phase where we'll be looking at mainly our clinical support services, and how we get good clinical advice into the ICB, and we'll be commencing that work as soon as possible once we've finished phase 2. But I'd like to thank our people for bearing with us and continuing to do the great work that they do as part of the community involved in health and care in Cornwall and the Isles of Scilly. Important to just check out around health creation. So we're moving on from prevention to health creation. Chris is picking up that mantle for the ICB, and it's the ambitious sister of prevention, which I really do like as a phrase. It's not just stopping people falling sick, it's the deliberate proactive creation of space, organisations, processes and infrastructure that builds communities. So I think that's called Rachel Wigglesworth's job, actually. It's your job. So we'll be having more of we'll be talking more about that as we go through next year. And then the last bit is an advert. So when I went to meet the Admiral nurses, I also met our fire safety officers who wanted me to get the word out far and wide. So I'm using this as the opportunity to do it. That they have to do a minimum number of fire safety home checks on a monthly basis. And I think it's something like 240 checks a month across the whole of the county. So if anybody's going anywhere near anybody's home, or any carers need to have access to support, it's just a really simple checklist. And if you score above a certain level, then the fire brigade come around to your house and they check everything for you. So I just wanted to make sure we were aware of that, and then we pass it on through all of our networks because it's a brilliant service. Thank you.
Thank you.
So thank you, Kate. Just wanted to pick up on the staff survey and actually reflect on our other statutory partners had their staff survey reported as well. And I have to declare a conflict of interest as an employee of my two colleagues either side of me, but they had an improving trajectory. So I think as a board, we ought to reflect on the good work that's gone into those two organisations. So Steve and Debbie, thank you.
Thank you, Andy. Neil.
So it's just coming back to West Cornwall Hospital. I have to declare an interest in that. When I can, I chair the Penwith Integrated Care Forum. One of the things that I've felt was a good thing was that you now have a development group at the hospital, and all I'd ask is that when we met with West Cornwall Health Watch down there, Kate, I did say at the time that whatever is put in place, bearing in mind the history of the nighttime closure, needed to be safe and supported, and that I'm glad to hear that that you're looking at doing such. And in any involvement with the development group, I think honesty and transparency is key, because if things are a problem, we owe it to our public to help them understand why there might be problems. I hope there won't be, but I also wanted to put in a plea that the kind of work that's being looked at in terms of supporting the Isles of Scilly with remote support for staff who may feel vulnerable and managing can be fed into that approach in terms of trying to look to how that may be achieved.
And we are, so Debbie will know that I'm really keen that the work that we do on the Isles of Scilly, we introduce to other islands that might not have water around them but have got gaps in service around them. So Bude, Looe, St Just. So we are able to share the learning we get from the Isles of Scilly around how we safely provide services all over the county. I mean, that's probably a couple of years away, but we're at the point of looking at how we do it. I think West Cornwall Hospital itself is probably a different issue.
Well, I'm certainly grateful for Neil's comments. I think it's absolutely right that services must be safe and must be sustainable to be appropriately in place. And the comment about transparency, I think, is absolutely right as well. So it'd certainly be my expectation that RCHT does whatever is possible to enable safe and sustainable services. If they are not able to be progressed beyond the current operating hours until midnight, I would expect that to be transparently discussed with local colleagues as well as with ICB. The position currently is RCHT is continuing to review and identify further options that could allow a further extension of opening times, but at this stage the operating hours continue until midnight. Now that is a significant increase compared to where we were last year, but clearly it falls short of the 24/7 expectations that have been discussed.
Thanks. I just wanted to highlight for the board as well that in response to the staff survey, the exec team have put some conscious and deliberate thinking into the plan for 24-25. So the internal development plan for the organisation will see the structure settle and be populated. That in itself will make an enormous difference to the capacity to ensure we're connected with our staff, but also capability building around things like clinical leadership, strategic commissioning, which are features of our model. We really need to put some time and effort into that, place development, other themes, and also the team building. So we're a very small organisation doing a lot of complicated work, and we're going to need to, we'll only be successful as a group of people working together. So we're going to be paying conscious attention to that. So maybe in future meetings of the board, we'll bring what that plan looks like, so that you can be assured of our progress in that regard, all of which will require active participation of teams across the organisation. Thanks.
Yeah, thanks. And I think we'd had a conversation previously, and part of what my future will be is about ICB development in totality. So we talk about separate organisations, but actually I'm also interested in a conversation, as you say, when we bring it back about what this means for the ICB in terms of that next phase. And I think that, you know, I don't want to lose that, but at some point it'd be good to return to that so we see it in a systemic piece as well.
That'd be great. Yeah.
I've started having conversations already with Ella Stracy. So one of the changes in our operating model is that we're setting up more of a delivery support unit where we'll have groups of people that will support different projects across the integrated care system. And I've been talking to Ella about how we align our QI approaches, how we align our programme methodology, because there's something around speaking the same language so we can celebrate together. So so I think as we go forward, we'll be bringing more of those examples back, Rachel.
Thank you. Thanks all. Thanks, Kate. Moving on to updates from committee chairs, just starting with Neil and QPOC. Anything to note, Neil?
Sorry. I think there's nothing that's springing to mind. I don't want to hold you up, Sanj. I wasn't quite ready for you.
Okay, sorry. I'll loop back to you if you do have anything. Tan, workforce. Yeah, sorry, yeah.
So really it's a time for planning across the year to make sure that we've got a clear work programme stretching out in front of us. I was going to ask Chris about a timescale for dentistry, but obviously he's had to step out of the room in terms of dentistry strategy that we talked about at the last meeting. But that will fit into our programme coming forward. And similarly with workforce, we're going to be looking at a date for the strategy to come.
Thanks, Tan. Nick.
Yeah, thank you. So our new committee has met. We're deciding to take the three clinical strategic areas of ICB priority and explore them one condition at a time, almost going, what are we doing now? Who are we missing? And the answer, how can we make it better? Using, as I said earlier, with those vignettes, how we access and people access in an equitable way and how we improve that access to care. But really trying to do that and understand that from all sectors of what we're doing and how we're doing. So we set our direction of travel, we've set our work plan and look forward to reporting back as the committee progresses, Chair. Thank you.
Great, thanks.
Excuse me, sorry. Can I just ask whether Health Watch Cornwall will be invited to join that committee? Because we were a member of the previous Citizen Engagement Committee, but we don't appear to have been invited to this new one. I don't know whether that was deliberate or whether we could possibly formally ask that we become a member of that, because I think the topic that you're discussing is absolutely a reason for Health Watch to be there.
Yeah, no, I'm really happy to really speak to me offline and let's have a chat about that. No problem.
Thank you.
Martin, audit.
Yeah, no audit committee meeting this month.
Okay. Neil,
Yeah, sorry. Just to highlight the final item that I wrote about in the Quality Chairs Committee was that the committee noted the intended work in the area of clear, improving discharge pathways across NHS Cornwall and Isles of Scilly, and agreed to endorse the direction of travel. The committee did wish to state, however, that the work ongoing in communities to promote admission avoidance remains a high priority for the ICB. Do you want me to do ICA?
Yeah.
Yeah, okay. In terms of the ICA, very much welcoming now the embedded financial team input from the ICB in ICA committee working, and that the ICA committee endorsed the direction of travel of the health creation model that it had looked at, and we know that needs to go through further governance, but very much recommended that as a way forward. Thank you.
Just before I move on to partner member updates, just from FPCC, which I chair, we had a good discussion and really positive in terms of where we are landing in terms of budget, as I said at the start of this meeting, with some great collaboration across the system to get us there. There are noted challenges we've set ourselves for 24-25 budget, and particularly around SIPs, both recurrent and non-recurrent, and particularly moving from non-recurrent to more recurrent SIPs. But there was a good signal from providers, I think, in the work that we've done this year that will continue into next year to get us there. But it was just noted that there are significant challenges, and particularly this committee being particularly diligent around SIP delivery from month one is something that we're going to be focused on. And where possible, working more closely with provider committees as well. And I was able to brief and have a very good meeting with the chairs of the counterpart committees at the provider level around this. Okay, I'm going to move on to partner members. Steve, is it all right if I come to you first? Yeah,
certainly. Just a couple of things to update on, if that's okay. Firstly, the operational position facing NHS providers, it continues to be very, very challenging. UHP have recently declared a critical incident reflecting the level of pressure that Plymouth and that system has experienced, and both RCHT and CFT have directly supported University Hospitals Plymouth either in terms of taking diverts for extended periods of time, or in terms of reprioritising community hospital capacity to facilitate discharge from University Hospital Plymouth. Royal Cornwall Hospitals and Cornwall Partnerships NHS Foundation Trust face significant operational challenges themselves, currently managing significant norovirus outbreak, particularly within RCHT, but also in CFT as well. So that additional norovirus challenge is reducing capacity that's available to flow patients from ED into RCHT ward beds or from RCHT to CFT. So that's certainly an absolute area of focus to bring that norovirus outbreak into control, and then to reduce the impact that it's having. Those two things and other issues are giving SWAST, our ambulance service colleagues, further sustained and significant challenge. So the operational environment is certainly a very challenged one. Colleagues will be aware there's a national focus on improving emergency department 4-hour performance, and all providers and our system, Devon system, are taking every possible action to address that. The national requirement is that all systems achieve a minimum of 76% all system 4-hour performance, and our system is marginally below that. There's been a huge amount of effort to address that, and our system has experienced a number of days of achieving that performance or higher, but a number of days where that performance has been lower than that. So we continue to do all that we can to address that. A couple of quick updates in terms of some key appointments. SWAS, the ambulance service, have confirmed the substantive appointment of John Martin as Chief Executive, and from a UHP Derriford Hospital perspective, Anne James was standing down after, I think it's 12 years of leadership in that role, and colleagues at UHP have just announced the interim Chief Executive appointment. So Mark Hackett will be commencing in the interim CE role at University Hospitals Plymouth next month, and then I understand that UHP will be going out to recruitment substantively. I did want to comment on the staff survey results as well, if that's okay. All of our NHS providers have seen improvements to some extent from a staff survey perspective, SWAST, in UHP, RCHT and CFT. I did particularly want to acknowledge the CFT improvement. What we've seen there for the second year in a row is CFT have been in the top 3 in the country for community and mental health trusts for improvement in the staff survey results. I know comments have already been made, but I think it would be quite right to acknowledge that. A huge amount of work in CFT to support that increase, which is very positive to see. Also really pleased to see RCHT being in the top 3 in the country for improvements from an acute hospital perspective for staff survey results. And RCHT, in fact, we're in the top 5 of the entire NHS, all providers and commissioners for improvements in the staff survey results. So really, really positive to see both of those improvements particularly. And I know in both organisations' case, the intention absolutely is to continue with that level of improvement going forward. So that was just the update from the staff survey results.
Both providers to be commended on those results, particularly as benchmarked against the national data, and also the fact that that's been through a very busy winter with significant pressures.
Yeah, well done to our staff. Eh?
Yeah. Debbie, are you meant to be covering something?
Yeah, mental health.
On partner members.
I'm really grateful for the acknowledgement, and I guess the link I would like to make is happier staff make for happier patients, and that's why we're doing all of this. So of course we're absolutely thrilled to have 2 years in CFT, and Rachel will know that our cultural improvements were absolutely front and centre as part of our original governance undertaking. So we had a plan, we've stuck to the plan, we're continuing to deliver that plan, and our work will never be done in terms of improving culture. But we're at 66% now of staff recommending CFT as a place to work. That's above the national average of 61%. But the best community and mental health trusts are over 70%. So you can guess where my ambitions and our board ambitions are set. But I'm really grateful for that. Would you like me to just highlight my report, Sanj, while I'm here? So And I think the report today absolutely shows that we have been through a cultural journey of also empowering our staff to come up with innovations and to work differently and to think about collaboration and how we can provide personalised care to people that benefits them but also drives improved care across organisations. And I'm really proud to have in my member update report today the focus on children and young people's eating disorder services. And this initiative was funded out of efficiencies from the Southwest Provider Collaborative Tier 4 work. So that means that savings that we've made within the children's inpatient services has been able to be invested in a number of pilot projects, in large part designed to keep young people at home. And this work really highlights the joint work between CFT, and that's between our community and our inpatient services, but also our community services on mental health, our CATUs, in terms of upskilling staff. And we get fantastic patient stories now of young people who previously would have been taken to UHP or RCHT for all of their NG, nasogastric tube feeding. Now we've got a much better integrated pathway, and that forms part of their goals as a young person, because when they're very, very acutely unwell and sick, we absolutely need the specialist care that's provided in acute paediatrics in both UHP and RCHT. But having these incremental goals to work towards really helps. Staff are happy. I have Sienna staff feeding elderly patients on the CATU, while the CATU qualified staff are doing the NG feed tube. So it's that cross working and also relationships between acute paediatrics in UHP and RCHT have improved significantly with children's mental health services. So I know you've heard from me before. Let's talk more about children and young people. Let's continue to talk more about mental health and improving care. And I think this is an example that I'm really proud to present today.
Thank you, Debbie. Mary.
I'm not a partner, but I'm a attendee, and I would quite welcome the opportunity from time to time to give a feedback from the care sector. Would that be reasonable?
Absolutely.
I haven't prepared anything, but I can off the top of my head do a little bit now, if that's all right.
Yep.
We've missed budgeting opportunities. The fees have not yet come through with any percentage uplift for care homes whatsoever, but the wages go up on the 1st of April. So we are in a bit of crisis at the moment. So I just wanted to feed that back, that we are likely to be in trouble shortly. So contracts are out of date because I gather it's something to do with the NHS not having engaged yet with the council. Rachel may want to come in here because they're talking about it's been a joint contract for the last 3 years, and now there's a bit of a problem about whether health want to go in with the council, which is why we haven't been notified of any uplift. Others may well know more than I do, but it's not my pay grade. I wanted to say thank you to the council who's given Cornwall Partners in Care £50,000 for some more care coins. We had, for those of you who don't know, care coins are an online counselling service from an organisation called Red Umbrella. We had £80,000 a couple of years ago. They've all been well used. There's a little bit left. We're using them for mental health first aid training. We're using them for face-to-face, but online face-to-face training, which comes from registered counsellors across the country, so that people can choose the gender, they can choose, and they can do it in private. They don't have to travel to have the counselling, and it's working very, very well. We're looking at the moment at the delegated health tasks, which are causing some pressures because some of the community nurses or some people within the community nursing team are sometimes trying to delegate a health task without understanding the registered nurse liability of delegating something when they can't monitor or supervise. And we're having a bit of a pushback from time to time to say we can't necessarily take it on. There's a lot more involved in what can be done to make that legal for the nurses and safe for our staff. We're working through digital transformation at the moment with a variable success. For example, a lot of us went over to EMOR, electronic medications, some years back, but the pharmacies are now so struggling for their own staff and time that they are no longer in a position to enter the data before the medications comes out to us. So we have to put in extra resources to keep a member of staff there all night to go through, say, 35,000 medications to get them entered onto the system, with the consequent risk of us transposing figures. And these are not nursing homes necessarily, these are care homes. So I just wanted to give a flavour of some of the things that we face on a day-to-day basis. That's all. I'm not sort of making a thing about it. Is there anything else there?
No, thank you.
Can we clap social care? So people going through the winter as well. Thank you.
Carolyn, yeah.
Sanj, could I just make a comment?
Yeah.
So in terms of the delegated health tasks, we're picking up the vice versa of that. So we're asking Louisa Forbes, Kate, to actually give us some advice on this, because this is something that we just need to take a systematic approach to. It could be one team or one care home, or it could be across the whole county. So I'm really keen, Mary, that we pick this up and work with you on that. So
excellent. Thank you very much.
Should we put Louisa in touch with you, and then
we've been in touch with her too, but yes, if we can talk,
because we do want to solve this.
Yeah, thank you.
We do, because during COVID, our care homes were really active participants in delegated tasks.
Yes.
And we ask relatives to do that for people in their own homes. So
the problem is we don't get anything backfilled, so we get another safeguarding while something else gets missed.
So some of the homes have a different view about it. So I think you're quite right that we do need to. Some places are sad that they don't have delegated functions anymore, whereas other places perhaps don't want to have them. So because the market is so different, we'll have to, as you say, Debbie, make sure that we align it to the places where people are.
Carolyn and then Steve.
Can I just assure you, Mary, there isn't an issue between the NHS not wanting to kind of go with the uplift with the council. Council colleagues and ICB colleagues have been talking about it. The only reason there's been a slight delay is because obviously we're in our financial operating plan model, which is slightly more difficult this year. But I think we're just there or thereabouts, so you'll probably hear in the next 24.
I know we've got a duty under the Competition and Markets Authority to notify people of their uplifts at least a month ahead of time.
Yeah, I appreciate that.
We haven't got that now.
But you will have that.
Thank you.
Okay.
So that's really helpful, Carolyn, to have that update. That sounds, Mary, you're describing that as potential crisis. That sounds a significant challenge or risk, and I think it might be helpful for the ICB to have an update on the kind of outcomes of that, and whether the process Carolyn describes resolves the concerns you have.
Thank you.
So that we can be making our investment decisions for next year in the context of that risk.
I'd say it's fair to say, Mary, that if it's building towards a problem in terms of when you're required to notify your staff.
We can't even start our budgeting yet, and we're a week away from April.
No, I know, but I would suggest also do raise it earlier as well, in February. And I'm glad we've given you the opportunity to update us today, but, you're part of the group.
I think it's quite important as well, Rachel, if the message back to the care homes is if only the NHS have got their act together, we'd be able to give you the uplift, because then we could, I'm sure that isn't how it's been said, but it's how it's been received. So I think we will take this offline to make sure that working in partnership doesn't cause issues to any part of our system. So will you pick that up, Carolyn?
Certainly will.
Thank you.
Okay, thank you, Mary. Just any other participant updates? Yes, Emma.
Just very briefly, I just wanted to recognise the board's continued commitment to channel shift, actually, and I'm not going to go into the detail of the report because people will have read it, but I think this is a real recognition of how we need as a system and actually as a nation, to be honest, to move towards a more preventative work if we want to continue with sustainable services. So I've been really grateful for Simon's support and the team to help us to do more detailed work on the diabetes element of that. and to bring something back to future board. But the bit that I really wanted to just draw people's attention to, as Debbie mentioned in her conflict of interest update earlier, was just a reminder of the variety of organisations out there who are really struggling, I think, financially in the voluntary community and social enterprise sector. So it was great to be able to see the Community Foundation Award, which was money that was given by the ICB in its previous incarnation as a CCG, which has now gone out to 67 organisations. And I think the fact that we had £1.4 million worth of applicants really demonstrates that there is a tough situation out there for my sector. So I just wanted to highlight that's a great piece of work, and actually the board should be really proud that they are putting funding into voluntary community social enterprise sector. And when you're seeing grants of £1,000 that actually make a massive difference to really small community groups, it really does matter putting that funding out there. So thank you, and I hope we'll be able to bring back to a future board impact of that funding.
Thank you, Emma. Brilliant. We're going. Sorry, Andy. Yeah.
Just on a part member update for primary care, just to reflect, this is a very general medical practice focused, but with different methodology, hundreds of thousands of contacts per month in general medical practice in Cornwall, and recognising how busy the sector is. And I just wanted to highlight also to board the national picture around contract discussions that are out with our control, but may have an impact on general practice from the 1st of April onwards.
Stuart, did you want to add anything?
Yeah, thank you. I mean, in the paper, Andy has recognised or shown the data in terms of primary care access in Cornwall and the number of appointments that are being seen. So probably half the population accessing general practice in December alone, and certainly when benchmarked against other parts of the southwest and indeed the country, should be noted that primary care access in Cornwall is really, really good. I think, and he's already touched on it, and it's in his report as well, there's some significant fragility there though as well. So despite the high performance of primary care, there's a number of practices who are on the edge of contracts being handed back, and I think we've made it pretty clear to Chris and to Kate, who really have engaged with the discussion. So thanks to them, that actually the 2% uplift in our contract set against probably 10% increase in staffing costs next year because of the increase in the minimum wage, and then the knock-on effect that has on the rest of our kind of pay structures. It is significantly going to impact primary care. So certainly reflecting on myself and some of our larger practices, we are going to be asking for staffing freezes, national wastage, and sometimes reducing clinical staffing. In more extreme cases, we're really quite concerned about practices falling over because of those financial pressures, and the general thoughts are that those financial pressures are felt worse in areas of deprivation as well. So I think it's really important to just highlight as a major risk to the board the financial pressures on general practice for next year. And of course, it's not just general practice that affects. Less clinicians will inevitably reduce access for our patients, and we know that when practices fall over, of course, it has a significant impact on the front door of ED. So I think it's important that the board hears the risks around those financial pressures for next year, not just for general practice, but for the system at large.
I think it's worth, the practices we met with yesterday, they are some of the practices that are also some of the highest referrers into our CHT in our current models of care. So we need to take really seriously the potential for further system destabilisation of those practices are starting to fall over. Now, I say this with a little bit of shame, but I hadn't really thought about when we have our National Pay Review Body recommendations around levels of remuneration for clinical staff. The NHS through provider contracts is funded for those pay increases general practice isn't. So if there's a 2% uplift in the GMS contract and you're employing nurses and OTs and physios and paramedics and pharmacists, then you don't get that money passed on to you. So there is just something around a year-on-year impact of that not being handed on. And this year with a 1.9% offer to general practice, nationally there's an issue. But locally, we need to do our heat mapping to make sure that we're managing our issues so that we continue to try to improve out of hospital access, not make it harder.
Rachel.
Can I just add to that? Because I think that's clearly an issue for primary care, but also highlighting that the council, under the Public Health Commission responsibilities, also employ NHS staff, and our pay settlement was 1.3%. And obviously with pay awards for health visitors, for nurses in sexual health clinics and a whole range of clinical teams, we're in exactly that position. So again, a risk that, these are traditional health treatment services, and we, as a system, there are a number of pressures like that, but not wanting to detract from primary care. And this was just a question about, is that the issue that Stuart raised, is that relevant to be added to the risk register in a specific way in the later discussion?
So we're hoping that we will work with general practice to mitigate that risk. So we haven't quantified it yet. We've agreed some principles through which we'd work with general practice yesterday at our meeting, and we now need to work through that. In terms of the public health grant, I'm sure Ali, if Ali was here, she'd be talking about rising costs in residential care as well. So there is just something about what we can do from an NHS funding perspective, and then how we engage with the local authority around some of our joint responsibilities.
Steve.
Yeah, thank you. Andy, I just want to acknowledge the 46.9% of same-day appointments, highest performance in the Southwest region, which I think is really positive. I think it might be helpful for us in future reports or in the IPR to have sight of those appointments, which ones are accessed through 8 o'clock in the morning contact to the GP surgery. I understand that we've got a range of ways in which of accessing those appointments, and in some surgeries it is kind of accessed or controlled through an 8 o'clock or similar time in the morning call, and I understand that patients will have some challenges being able to access those appointments. So firstly, acknowledging that really positive performance, but I think it would be helpful for us to have sight, if it's possible, as to how that in reality is accessed across the different practices.
Thank you. I'll take it offline and have a little think about how we bring that detail. The methodology will be challenging because of the numbers, and we'll work out which governance route to bring it through. And I'll look across to Tarn and probably bring it through PCCC and Chris in his executive role. But we can try and answer the question.
Okay. Thank you, Andy. Nick, have you got your hand up on the screen?
Yeah, if that's okay.
Yeah.
I just wanted to just come back to what Stuart was talking about just a second ago, and reflect back on the King's Fund reports that's been attached, and the direction that it was talking about. And we talk about channel shift, or certainly channel shift is mentioned over and over again in sort of ICB meetings and certainly ICA meetings as well. I just want to be clear, there will be no channel shift without general practice, and there will be no general practice very soon of any functioning ability if the squeeze continues that we're seeing at the moment. Stu is absolutely right that our practices are falling over. We've lost 3 practices in the last 3 years. I've got another one which is potentially handing its contract back in 2 weeks' time, and these are due to financial pressures. That they're not because no one wants to be, no one wants to be working those practices. It's the fact that they just can't afford to run their staff. We've got another 2 practices, and one of those is about the largest practice in Cornwall, who are asking for financial assistance because they can't afford to pay their wage bills, and if it's 2% uplift goes through, I can only see two outcomes for general practice in Cornwall, and that is to follow a national leadership and move towards industrial action. And GPs are the only sort of doctors group who haven't been on strike, you know, over recent memory, and in fact, I can't even remember the last time doctors did strike. I think it was over pensions, and it was just to work to rule for one day. But the other possibility is the fact that, and this is a real threat now, is the fact that people are going to have to start laying off staff, and if they lay off staff, that means that their offer to their patients is going to have to reduce, because we can't offer what we are offering at the moment with less staff. And so I just wanted to reflect that, because I'm not sure, and everybody in this room is aware, and they need to be, and I hope they are now. And Kate and Chris came to the collaborative board and sort of said, look, you know, what can we do to support general practice? And two things popped into my mind, actually. The first is the ICB could write to you know, our Secretary of State, to Victoria Atkins, and say, we do not support the 2% uplift to general practice. We understand that it's going to be detrimental to the health of our Cornish patients, and we ask the NHS to look to the King's Fund report, look to the investment in primary care, and ask them to reconsider their 2% uplift. And the second is as Kate and Chris know, is we have been trying for the last year and a half or so to introduce the mandated to the ICB meetings between primary and secondary care to discuss the workload shift which is going on, and the swamping of primary care. And as of this time, UHP and general practice have attended all of the meetings, and we haven't had any secondary care providers yet. Just wanted that to be minuted, please.
That is a serious issue. I know there's been discussions offline and even before this meeting, so some of us are aware, but thank you for making all of us aware about it and your suggestions on what actions need to be taken. Very quickly then, Chris, yeah.
Yeah, so it's just to help Nick, I've already taken this issue to the regional medical director and flagged it as a serious concern. So the regional team are well aware of my concerns with the issues that Nick and Stuart have raised.
Can I just look to Rachel, because I think nationally, so the national NHS executive from NHS England, they're very clear that this is an offer to general practice that will have catastrophic impact, aren't they?
I mean, across NHS England, we're challenged on all our budgets, and I'm having the same conversation about public health budgets as well. So I think inevitably, I think it requires us to think as creatively and as differently as possible about how we deliver care, but nobody is alone in that respect.
So my understanding, the issue has been raised nationally, so as a concern. So we will continue to work with you, and in terms of sorting out the interface committee, Chris and I have made a commitment to doing that, Nick, at the GP Collaborative.
Yeah. Thank you, Kate. Is it urgent? We're really over, Nick. Do you want to do a... Yeah.
Seconds, just I'd echo primary care, and Andy normally articulated does very well. Primary care is more than general practice, and just all those things apply across all the things that we commission. And the second thing as well is just now when you talk about capacity, I think there's an offer from, I'm going to give Drew a job, that actually we commission a walk-in consultation service that has capacity of where people access care, and also NHS England are holding the data on Pharmacy First, which will show again capacity. So I think when you're talking about patient contacts and touch points, just don't forget that additional capacity. That's all.
Thank you. Thanks, Nick. We're going to close this part. We're not going to go to winter planning update, because I think, when do you need to go?
So we could do it in 15 minutes, couldn't we?
Can you? You've got time. Great. Okay. Thank you.
Thank you. So I'm aware from the previous board meetings that the winter plan is had some questions raised around the delivery of the schemes and the impact that's having. So it was an action that was taken away was a system-wide collective view about the impact that winter plans had had. I think, as we have heard from multiple colleagues this morning, the pressures are still very, very much live and with us. But I think we've also learned this morning and heard some examples of the great delivery of some of the schemes, the X-ray car being one of those. It's been up and running. So So just in relation to the paper that's been circulated, it does indicate the position of the schemes where they were at time. And I think it's important to also recognise that there has been some great developments of schemes from initiation. This wasn't a development of existing scheme and emphasising it. There's been some new schemes set up very quickly and delivering incredibly well. So I think most of them are front end loaded in community, which is the absolute right purpose. Remembering the two key aspects of this is stemming demand into very busy providers by serving patients in the community, and then supporting the discharge capacity as well to drive this. So I think there does need to be recognition of the speed and delivery of some of these schemes of setup, recognising there were some delays in that mobilisation, and understanding the value added is still an ongoing piece of work. But I think if we look at some of the numbers that we're seeing of avoidances, the right care car seeing the falls car seeing double numbers plus each day, the care coordination hub removing 40 patients plus from the stack each day, there's some fantastic work going to drive. That said, unfortunately, if you look at the key drivers, and I think it's slightly crude to look at them in this nature, of the ambition was to do 20 fewer attendances, 9 fewer admissions as a front-end aspect. They were very crude in their nature of a view. And if we look at the delivery against those, sadly, we haven't seen that improvement against last year's figures in relation to delivery. But I think it's really important that we note the delivery they have achieved and what the position would have been if they hadn't been in place. As was heard last time at the boards, the aspects of driving discharge are the ones that we've not seen come to fruition, and these were around the dementia hub and the additional P2 and P3. So patients with a non-criteria to reside across our acute and community, and including into Devon, do remain very challenged. That said, if we reflect back to figures this week to figures a month ago, we've seen a decrease of 50 patients who were waiting as a non-criteria to reside. So that's gone from 250 early February to 200 early in March. So there have been improvements in the discharge aspect, but we can't directly say that's been through the developments of these schemes. I think there is credit to do in there to the CHS scheme that come live into supporting discharge and the in-reach they've done with some of the voluntary sector work. So I think from an overall perspective, the matrix were crude. Proving what's been hugely beneficial is live from patient stories. The numbers will come online to support that. I think last month there was some anxieties around the primary care delivery and commitment of 12,000 extra slots to be delivered through the winter. And there was a proposal that went to SEG. There was 3 proposals that went to SEG following the understanding of surplus funding from these schemes from the slippage. Primary care have exceeded in addressing that further. So although they've not delivered the 12,000 as initially stated, at the last board, I think we were looking at about 2,000 appointments, but they've managed to deliver that up to just over 5,000. So they've delivered 45% of their initial commitment, and that's been tremendous to achieve that, given the resources and pressure that's already in primary care. So I think the target initially set was very stretched. So again, commended to what's been delivered through that. We've also made a commitment to provide additional Pathway 1 capacity. And again, sadly, that's not been delivered to the numbers we were expecting because of the availability of the market in the areas where we need it to deliver that care. And the final aspect that was proposed, apart from that surplus funding, was the 1/3 commitment of the CLEAR programme to support a longer term discharge to assess model for Cornwall. So that's been mobilised. That's not a delivery for this winter. That is a staggered piece of work, but they come and help deliver that scheme. So it's very important, and with national support for that as well and funding. So that's also been mobilised. And an aspect that we've also this week supported through that winter fund is recognising the pressures that were in ourselves, but also within UHP of their critical incident state. We have supported some additional bed placements for Cornish residents within the Devon system. Longer term is clearly really important to understand what we do with these schemes, because some of these, well, most of these are
have got an aspect that cease at the end of this month. And it's really important that we can't stop some of these schemes and carry them forward. So as part of the ICB's priorities of understanding 24/7 services and the discharge to assess model, these very much fall into the programme assessment and where do we take these moving forwards. So that's a piece of work we rapidly need to understand about how we make sure we deliver these schemes moving forwards and understand their true value. But I do just want to re-emphasise that this is a moving feast, and things change on a daily basis with the pressures we're seeing over winter, and the collective effort across the system to respond to that has been fantastic. And I do just want to thank again to those providers that have put the front end schemes in, especially to support attendance and emission avoidance, because there's some brilliant stories there. Thank you.
Thank you. I'll open it to the floor for questions. Yeah, Martin.
Yeah, thanks for that. I mean, a couple of thoughts. I suppose, congratulations on being fleet of foot, I guess, and standing up some new things when the other things were proving more difficult. I think on reflection, we, as a board here, when we first had the plan, there was a little bit of concern expressed that we were focusing a lot on sort of pre-admission avoidance rather than flow out. And so it's especially disappointing that the little bit of flow out, didn't really come to fruition. And I suppose the thought around that is, how do we avoid falling down that trap next winter, which will come around, pretty quickly already. So can we not, and I think you've touched on it maybe with the clear thing, have some things that we're starting to pre-plan now so that we know that we're not going to sort of put our eggs into something that can't actually have been delivered when it comes to it in, 6 or 7 months' time. I think reflecting on the thing about going into next year, I'm almost piped up on the GP one just now, because we do need, I think, to have a sort of clearer plan about what our sort of strategy for primary care GP bit is. And, I know there was a little bit of a thought about, the primary care hubs being there to support GP land as well as being there to support avoiding admission. So it looks to me like what we've delivered is actually pretty much a drop in the ocean compared to the number of GP appointments that we see every month. And I can't really believe it's made that much difference to hospital admissions, but maybe some. But I do think particularly for that, we need to wrap that up into, what are we doing as our bigger picture primary care GP plan, come for the coming years, I would say, because that may or may not be part of the solution. And it's probably particularly difficult in our geography where we're not all close to one of those hubs. But so I suppose it's sort of mixed support from me. Good news, great, we've managed to fleet of foot. Some things are clearly working well, but it is a shame that some of the things we planned just couldn't be put in place.
Thank you, Martin. Let's just collect a couple of questions and then I'll come back to you and Kate and Leighton. Steve.
Yeah, thank you, Leighton. Welcome the report. It's really clear, and I'd certainly echo your congratulations on the schemes that have been delivered. I think they've all made an impact, and even in a context where some of those schemes haven't delivered, we should acknowledge the delivery. So thank you for the report. Just a couple of comments or questions, Sanj, if it's okay. One's on a funding availability perspective. I think our industrial action funding that's being provided is about £500,000 short of the actual costs that are being incurred. So it'd just be useful to understand whether that has any impact on the availability of funding for this as a first question. Secondly, I welcome the P1 spot purchased capacity, but in the context of the kind of earlier discussions, be useful to understand of how confident we are that the first tranche of 60 packages and the option of the second tranche of 200 packages, how confident are we that that capacity is there to be realised? And I think a final comment for me is around Easter and just the way Easter falls this year. It's into the new operating year, and from a flow perspective, there would be a strong kind of desire to see all of these schemes continue at least through the Easter period, and clearly, Simon, that gives different challenges going into the next year, but I am mindful of the challenges that we'd expect to be seeing during the couple of weeks of the Easter holiday period.
Thanks. Debbie?
Yes, I really welcome the report, and I also welcome the fresh eyes and the attention to data that Leighton's brought with him. I think we have seen a significant improvement to our system calls and our gold calls, and I'd like to actually thank you for that, Leighton, because it's really reassuring to have data that we know we can rely upon in an actual way. So thank you. The absence of schemes that were able to be stood up for the P1 to 3 out there points to me, picking up on Martin's point about we need to do much more about market engagement and market stimulation, because the markets just won't appear. And we know we've got particular challenges being in a peninsula, but my question specifically is what work are we going to be doing now to ensure that we have that capacity that we need for next winter? Because with that greater clarity of data, we also have greater clarity about what our needs are and what our demands are. And I would also like to add that whilst I'm delighted that the number of people on a Home First Pathway 1 delays have reduced, they've halved, and they are 2/3 down on when I was escalating to this board my concerns. So they currently stand at 7, but 3 of those are over 100 days. And that's the sort of specialist capacity that gets used up waiting for the market to respond to some of those long-term packages of care that are absolutely needed to keep people in their own homes. So I would like to hear more about what's our strategy in the next quarter for procuring additional support for next winter.
Thank you. Who'd like to go first, Leighton or Kate?
So if Ali was here, I think she would talk about the procurement that the local authority have been taking forward around additional capacity, but based on geographical lots. Now, unfortunately, the procurement rules changed midway through because it would have been a joint piece of work, but we can't join the council in that procurement. So there is a bit of a delay working out how we would join, or if the council would go without us, and then we would join a procurement at a later date. So that's the market response answer. It builds on the Finnish model that I think Rachel Rotherham has spoken about in the past, where it's it's micro commissioning within communities rather than commissioning for Cornwall at scale, because we know that doesn't work. In terms of the schemes for 24-25, the discussions that we've had as a collection of NHS providers and commissioners around what we need to put in place in order to be able to have models of care that don't cause more need. So if we look at our current lengths of stay, it's not this simple P1 capacity, going home and a couple of visits a day and helping with your medication. It's the complex P1 capacity of double-handed 3 or 4 times a day visits that we can't find a market response for. So one of the discussions Ali and I would like to have is around if we use the Better Care Fund to invest at the front end of the pathway. So we've got more simple P1 response that takes people home as part of D2A using virtual wards and not looking at bedded solutions. So that's all part of our 4 or 5 schemes that as a collective we're saying that we need to put together to stop people going into hospital and staying there too long. We're just going through the process of modelling those schemes through, so with some confidence we can say what the clinical impact, therefore what the financial impact will be, but they're all built around harm and risk reduction. So I think between us we are saying that that's what we're going to do. This is my 8th year in Cornwall, and we have significant issues around encouraging people to want to come and work in care. But as my hairdresser said, when you talk about it when we talk about it, we don't make it sound that great. So why would people want to come and work in something that we don't applaud rather than criticise? So I think being part of the Proud to Care campaign with the council and making sure that recently retired people are attracted into the care market as well as young people. We probably need to diversify how we are communicating our requirements for our population to people who would be able to help with us. And some of the Work Well programme I think could maybe give us a focus for that, because the Work Well programme is looking to identify people who aren't economically active within Cornwall and the Isles of Scilly, and care could be a great place that we offer as a support for that. I don't know whether I've answered all the questions. Is there anything else?
I think the aspect, just to go back to the question about the P1, this is an ongoing challenge to secure in relation to making sure that the cap around the hourly rate becomes, of not breaking that and destabilising the market, becomes a very challenging position. Of there are often offers exceeding the cap, and we know the damage that could collectively bring. So as we sit talking right now, there is a P1 task force underway to really understand and meeting on a daily basis around how can we do something, because these are our biggest quantity of patients that we can make a difference to the 200 non-criteria. So it's very live, it's very active, but it's also very fragile. And I think just going back to the winter for next year is we have got a lot of reliance, and we need to wrap around the CLEAR programme for next year, because that does deliver the very much needed discharge to assess model that Cornwall needs. So that is a complete comprehensive review of our very over-prescribed bedded model, and a drive to move people out of other provider as soon as they are fit to do so. So we'll be very close, and as collectively be very close to CLEAR as a drive.
Just before Steve comes in, I think I was trying to see whether I could see our waiters for today, but around 50% of our waiters in RCHT are waiting for reablement, and half are waiting for bedded reablement, the model for which is not great. So, and the other half are waiting to go into a community hospital, another bedded reablement route. So the D2A link here, discharge to assess, is really important around how we move to models of care that other parts of the country have already moved to, where the assessment takes place in somebody's home, in their own environment, not in an institution. So as well as focusing on P1, I don't want to lose the link that that is a service that gets people back to their own house when they are capable of doing so. But we have groups of people who we could help to be capable to live in their own homes, and we should be doing everything we can to do that. So I just wanted to make that clear, not just for this board, but for the people who are listening.
Thank you. Steve?
Yeah, if I could just briefly comment, Kate, I strongly support the discharge to assess summary that you've just given, and the admission avoidance and supporting people to be back in their own home, absolutely. But I also recognise that the kind of specific challenges of complex dementia, residential requirements, and I know we've talked about that a number of times at the Integrated Care Board, but whether it would be helpful to have something back to the Integrated Care Board partway through next year about what further radical or other options are there specifically at a Cornwall level for those people who do need specialist complex dementia residential capacity. I don't know what the answers would be, but I know colleagues have really given that significant consideration. So whether there is a particular bedded aspect that we could have back.
Yeah, I'd echo that. I mean, my key takeaway, as Martin has also mentioned, is lessons learned and what are we going to do differently next winter. And I think for me, there's certainly a call for an earlier discussion around winter planning than we did this year, as well as an adequate mapping of risks that we need to flag in terms of any investments, and whether it's estates or workforce or other areas that will impact any winter planning. So that's got to begin, I think, earlier this year. Go on, Kate, and then Myri. Yeah.
So when we look at our breach reports, because I'm finding it's terrible that we've got breaches, but it's great to see the unmet need that is described in those breach reports. Out of hours, so after 8 o'clock in the evening and till 8 o'clock the next morning, we are sending people to hospital for whom we could have an alternative option. And some of the people that we send to hospital will look like they've got complex dementia within an institution, but when they're in their own homes, they might just be a bit forgetful. And so one of the things I'm really passionate about is that we don't pathologise age and cognitive impairment, that we look at the least restrictive way of providing care for those people that squeezes the last drops of joy out of life. It isn't just about living in a care home. So I think the challenge around dementia is well made. I'd love us to use our breach reports and our knowledge from this winter to be talking about what alternatives we should be planning that make sure that we've got great services for an ageing population in Cornwall and the Isles of Scilly.
Thank you. Kate, as previously noted, needs to step out for an urgent meeting, so we'll carry on with the agenda, noting those points. Thank you. We're going to pause on the integrated performance report till Kate returns and Chris, and move on to the risk strategic scorecard, and then we might take a break and then come back to IPR. Molly, have we got you online? Yeah, I can see. Molly, we can't hear you, no. That's not our end, is it? A problem? No. No. Sorry, say something again, Molly. I think something's coming through.
Can you hear me now?
Yeah, I can hear you.
Apologies, I don't know why this happens. So thank you for the opportunity to present the scorecard to the board this morning. As the paper highlights, this is the last scorecard of the financial year, and we're going to undertake a key piece of work to refresh the document before the start of the new financial year. It's probably just worth highlighting that in the document there are quite a few risks where controls remain assessed as partial. This is not uncommon for strategic risk, possibly in our case because it's a new document, they are still embedding and developing. However, for the new version that we provide from April, we'll be quite clear in cases where the controls are partial because they are delayed in implementation or because further action is required. So then in terms of the 24-25 period, I just wanted to highlight that we are proposing a slightly more dynamic approach to reporting, which will allow us to understand whether we've got adequate controls which allow us to stay within our risk appetite, and also to robustly review our target risk rating. And wherever possible, we're going to be mapping our BAF to our board forward plan. And I've heard conversations during the course of the meeting, for example, where we're talking about the need to understand the mapping of risk to some of our key areas of concern. So we very much need to make sure that our BAF is aligned to the key areas we should be talking about on the board forward cycle. And so really for this version, the board is asked to note and receive the strategic risks which are highlighted in Appendix 1, and to agree the proposed steps to refresh the risk register and the BAF for 24-25. I will just pause there and see if there's any questions, Chair.
I don't see any hands up in the room. Oh, no. Yeah, Martin.
Thanks. Yeah, I suppose not a question on what's there at the moment, but obviously we've talked already today about a couple of other risks that aren't highlighted on here, so primary care fragility, for example. And I know the process is not to raise things here and they go on there, but what's the process for those to be sort of considered by the exec team or whatever, Molly?
I think that's an excellent question. So in fact, one of the key things that we've started to look at is emerging risks. So I think what you're highlighting is the process for ensuring emerging risks are inputted onto the BAF or the corporate risk register as possible. So during the course of this meeting, I've been making some notes of some risks that we need to consider, and I'll be discussing those at the next exec meeting where we will have this item on the agenda. And one of the items for consideration is that those risks are put on. And then we'll go to the relative committees and propose the findings of the executive committee's discussions. So I think it's worth flagging that whilst the executive committee as risk owners can make suggestions and proposals, we do have a process where we provide output and recommendations to committees who will then endorse items for board approval. But obviously, if a risk is so clear that it needs to be inputted, it's a clear case of it goes on and it goes through the route of board committee to board.
I think I think we just need to check, but I think the primary care committee already see the general practice fragility risk. So we will double check that. But as I say, I'm pretty confident that already comes to PCCC.
Okay. Molly, do you want to carry on?
Yeah, so I was just going to see if I've answered Martin's risks question appropriately. But I suppose one of the key things I was going to add was when we do come back to provide the board with a BAF document for the 24-25 period, we'll highlight the risks that we've added and the ones we've discounted and the rationale for doing so.
Thank you. Rachel.
Thank you. And I think this is a really clear layout. I really welcome that and the work that's been done. Just in terms of the next financial year, I note that the sort of strategic objectives are all based on the True North, which now feels a bit dated. And I just didn't know what were the sort of forthcoming strategic objectives. Have they been agreed to then refresh this for the new approach? I'm not clear, but maybe others are.
Yeah, I think there's a live discussion around the number of strategic priorities we have and to try and focus down in 24. I don't think we're in a position to firm those up at this point, but I know as part of also John's objective setting with NEMS, but also with region, that's going to cascade down and will most likely be discussed here. So I'm pausing on this in terms of providing you a concrete update on what those are. But there is a clear desire to have a fixed number of strategic priorities for 24-25 that we can keep refreshing and coming back to, and actually also discuss in our board away days as well. So fewer priorities and relentless focus on those few is the intent, but we're not yet there in terms of what those will be.
Yeah, and I really welcome the sort of a broader discussion, like what, you know, the engagement through a type of True North or a smaller version of that, because I think it really gets people to understand the framework that then a lot of the approaches are structured underneath. And if that's not sort of jointly committed to, it can go feel a little bit difficult to follow, put it like that.
Yeah.
Thank
Some of this might overlap into the joint forward plan item coming up after the break. Yeah. Okay, thank you. Thanks, Molly. I'm going to just propose we do our coffee break now. We still have IPR to do, and then we'll carry on with joint forward plan. So if we can take 10 minutes and come back, that'd be great. Thank you.
Thank you. We're just going to hold off on integrated performance reports for a little bit longer until Kate rejoins. And we'll move on to the joint forward plan, which is what I have next on the agenda, Carolyn, if that's all right. And then if Kate hasn't returned by then, we'll also move on to financial update and the modern slavery statement, eventually returning to the IPR. So don't worry, we will come back to the IPR, but Kate was keen to be here for that. Yeah, so over to you, Carolyn.
Yeah, could you just give me 2 seconds to get into my laptop, because I need some of the things that are in front of me, and for some reason it won't let me in.
No worries.
No, this one, the joint forward plan.
Okay, thank you, Chair. So I'm going to take the pack as read. I just want to kind of put a bit of context. Obviously, the joint forward plan, we have to refresh it every year. We're supposed to refresh it in line with our kind of operating model. I think most people are still aware that we haven't had the operating guidance or the operational planning guidance as of yet. So what we've done is taken this along the lines of where we believe we are going. NHS England have asked that as part of the refresh, we reflect on where we've been and where we're going. And so far, we've actually circulated our draft joint forward plan update to RCHT, CFT, the local authority, and NHS England have already done a brief overview from it. So we've had some feedback from RCHT, which has been incorporated already. So this is now not a live document, and RCHT's amendments, changes have been incorporated to be looked at System Executive Group on Friday. CFT colleagues are looking at it at their executive management team on Monday. And we've had feedback from the Integrated Care Partnership already. As I say, we've had some positive feedback from NHS England stating that they can see where we've strengthened things like the health inequalities pieces and some of the other areas that we believed we needed to strengthen. As I say, we've had a sign off from the Joint Health and Wellbeing Board about a forward statement to go into it, which is a requirement. So the reason for bringing it here today is obviously to ask again for any further comments from partners and people around the table. It's going to the extraordinary general meeting on the 20th, where the operating plan will be signed off alongside the joint forward plan, because they need to go in together. I think the ask is just for people to keep feeding in any comments that they have. As I say, we've had some positive feedback from partners, and I just want to thank them for that. But Chair, really it is for bringing today to ask for any further feedback, any comments, and obviously there's a recommendation there that we would like a decision on today.
Thank you, Carolyn. Tan.
Thanks, Carolyn. Look, I'm going to say I really welcome the sense of direction of travel on this forward plan, and I'm really starting to see it being an iterative process moving from 1 year into the next year. I can see better linkages with the council's priorities as well, and a cut across. And I'm really heartened to see a raising of the equity of outcome and also of mental health within the forward plan. It's not job done, but it's certainly taking us in the right direction. So thank you to you and your team for some great work.
Likewise, I think it's looking great, and mine was more of a what could we do for the future. So I really like the 3 elements of the joint forward plan. It makes things so clear about what we should all be contributing to, and I wonder how we can take that into our board and committee structure over the course of the next year, so that we're all ensuring that we are identifying any reporting, any projects or anything that we're doing, and how they contribute to each one or more of those 3 elements, because I think that would really help us to tie in the work we're doing to the forward plan.
Okay, thank you.
So, Chair, I was really enthused and excited rereading this plan. I think it helped me understand why I'm here, why we're here, what we're actually working towards, and a reminder of a lot of the work that's already gone on. So page 15 just goes to prove that bringing health creation type approaches and plans and papers to the ICB is a good idea. I just had 2 little points that I just wanted to just clarify. On page 18, there's a piece about health and wellbeing workers, and it says 1 integrated care area is testing or embedding, but actually 2 are already employing health and wellbeing workers.
Okay, we'll amend.
Thanks. And just one more, if you beg my time, Chair. On page 7, this is page numbers down the right hand side, because it's a bit confusing. There are a lot of page numbers on these. There's a bit about virtual wards as part of the approach. I just find it. Expand use of virtual wards for people who've been to hospital to complete their recovery at home when it's clinically safe to do so. I appreciate that is a use of a virtual ward, but a virtual ward is also has the capacity to avoid an admission in the first place. So I just wanted to make sure that the statement we were making there was actually reflecting what is a more accurate reflection of what virtual wards can do for people. Is that okay?
Yeah, that's absolutely fine. Thank you.
I think that's right. I'm saying I think that's right. So I'm asking if that is right. Yeah. Is that
I will
okay?
double check before we edit or amend.
Okay.
Yeah. Debbie.
Yeah.
Okay.
So, as the lead provider of virtual wards, Neil, you're absolutely correct, and I missed that. So I'm really grateful, and I think it is absolutely recognised nationally, regionally, and locally that there's as much value in using virtual wards to provide step up from referrals from primary care, urgent care response, ambulance response, and so on, as there is in terms of the step down. So it is very much a mixed model, and I'm grateful for you picking that up.
I just forgotten what a good document it was, and I wanted to reread it.
Rachel, yeah.
Thank you. I think it's showing that level of maturity of really being able to reflect both the priorities in the integrated care plan, the ICB strategic priorities, and some of the joint working with partners. So I think it's a really good document. I think it's for us to hold ourselves to account to actually deliver the ambition in it, because a lot of it is ambition, but there's also some more specificity, which is really good to be able to name specific pieces of work, not just the intentions, which I see in this version of the document. So agree with Tan's comment about it's getting there, and also wanted to recognise the proportion of that is related to children and families as well, because I think there has been a tendency in the past to be more focused on adult care and services and approaches, and I think this does have a balance. And I obviously welcome the focus on inequalities throughout the whole piece, and the commitment to prevention across the whole as well. So just confirming that the chair of the Health and Wellbeing Board did provide a statement, I think, of support, and I was part of that discussion, having reflected this from the session from them supporting this.
Thank you. I mean, I support all the interventions here. I think my reflection also is it's great to see this. I think it's something we want to return to, obviously, throughout the year in these meetings, but also probably in our away days as well. There's probably a link we need to be making. I think Emma and Rachel have said this previously around what's in here and how this cascades down through the system. If we have unaligned documents that really is read and understood here, but isn't cascaded into the so what of strategic priorities and actions at provider level and other parts of the system, then it's really a standalone document. But I think also, even within this document, there are great actions, and what are we going to be doing? Our plan is to, in the various sections, which initiatives within our system operating plan do these actually tie to? Because our plan is to doesn't necessarily suggest, perhaps in all cases, that it's within the 1.3 billion or is sufficiently funded within the 1.3 billion. So I think that there is potentially even more work that we can dig into with this, notwithstanding the fact that this is a great starting document and a great reference document that we should all print out and have, and certainly bring to not just this, but also our away days. Carolyn.
Yeah, thank you. Can I pick up a couple of points? So Emma's point about the fact that we kind of like the operational recovery, the improving value for money, and also the transforming care headings. Later on, when we talk about the operating plan, we'll be talking about a narrative that will be coming to support the financial meeting on the 20th. And actually that gives the kind of detail that you're probably talking about, Chair, in the fact of, if we're looking at operational recovery, what are those things that are sitting specifically under there, and it details those. So I think we would be able to then use that as a kind of something for the board to reflect back on each month and have a look at under each of those areas, those particular initiative schemes, whatever, or metrics that we need to look at. So I think it is all beginning to come together. And just to pick up Rachel's point about the health inequalities, we had some good feedback about that, but as with anything with health inequalities, there's more to do around strengthening that. But one of the pieces of feedback we received from NHS England was the fact that they really liked the fact that we'd strengthened the innovation section, the sexual violence section, and also that there was a clear response to the feedback that we'd had last year. And so they could actually see that coming through in the document now, which was really, really good to hear.
Thanks, Carolyn. Debbie.
So I just wondered, Carolyn, particularly under the access to mental health services on page 10, where you've got A to H, if I think about what are some of the barriers to providing those, so I think they're comprehensive. Some of our challenge is about lack of timely discharge from inpatient units. And given what I'd already said about the winter plan and market stimulation and market engagement, is there a broader piece where the ICB has a role to ensure that we're working with partners to ensure that we have got a healthy market of housing options, whether that's your own home, an adapted home, or supported living and so on, because at the moment that's one of the things that we're stuck with.
Okay. So can I respond to that, Chair? Is that okay? So there's a supported housing strategy that the local authority are kind of working on at the moment and working through with a whole range of accommodation types within it. So that's around, some of that is around supported living and things like that. So do you think it's worth then linking back into that to kind of pick up those things from there? I see Margaret kind of nodding. Is that what you're talking about, Debbie? Or
Yes,
yeah,
I think it's just drawing that link, but maybe Rachel from the local authority might want to comment, but it is something that we're continually challenged by.
Okay, thank you.
So, I mean, it's been taken to the Integrated Care Partnership, that strategy for engagement and then sign off essentially through council cabinet processes. So it is been adopted.
Yeah.
And it's really comprehensive. I think it's the ambition and the delivery, milestones to do that. So I think you have had a copy and
I think it's about making the link across into this document rather than there
It's
not
not
being
mentioned
anything.
specifically.
It's just
Yeah.
not visible in here.
Okay.
You've referenced other documents that might be worth referencing.
Okay, thank you for that.
Whether or not it's here, I think there's a wider point around what are the barriers to the our plan is to sections. So it doesn't. I'm not necessarily saying adding to the actual joint forward plan document, but I think capturing where those are across not just on the mental health provision, but other areas as well.
Yep. Thank you.
Great. I don't see any other hands up. I can't see hands on screen. It's too far away, but pop up if you did have anything. Otherwise, thank you, Carolyn.
Could I ask for the recommendation, please?
Yeah. Page.
So members, I just asked to note the progress in refreshing the document and to just keep continuing with the feedback, please. Yeah. There is actually a recommendation that is not in here, and it should have been in here. It was to actually ask the board to enable the chair and the chief exec to do any minor changes ahead of the EGM on the 20th to sign off, rather than them having to come to the full board. And I can't see where that is. That looks like that's been.
It isn't there at the moment, but we can
I
put
would
that
like
verbally.
that as a recommendation to be added,
So,
because otherwise we'll have to circulate it to everybody. And there is an EGM, but obviously we're talking minor changes here. Clearly, if there was anything significant, we would make sure that that was circulated round.
Margaret, that's I think a reference to the 20th of March scheduled.
I hadn't heard it called an EGN before that.
Oh, extraordinary general meeting.
Is it a general meeting though, or is it a
extraordinary meeting?
Board meeting, yeah. Okay. Sorry.
Okay. It's the meeting on the 20th of March. So the two recommendations are to ask the members of the board to note progress in refreshing the document, which is written there. The unwritten one is to allow the chief exec and chair to make minor changes between now and that meeting on the 20th of March. I can certainly perhaps suggest that the chair and chief exec just highlight to us any changes that they make, so we're not trying to comb between two versions. But I think it'll be in the spirit of minor changes between now and March. I think if there are any further comments or input, I think Carolyn really needs it by early next week from members to incorporate before the 20th of March.
Anything by close of play Monday, please.
Yeah.
Because ideally by Monday morning, because the papers need to go out for people to look at them before.
Carolyn.
Thank you.
We'll keep going and come back to IPR. Financial update, Simon.
Shall do a brief update. All the microphone works, that's good. So following the reference earlier, I think the most important thing at this stage is to clarify we are going to be reporting a break-even position at the end of this year. All the organisations are comfortable with that, and so despite all the variations in operational performance and issues that we've had to manage, we're clear we're going to get to that position. So I think that is a very positive thing, and organisations have worked really hard to drive that through, following on from last year as well. Which I know, whilst we recognise there are some areas like CIP we have to get better at on a recurring basis, there are clear benefits coming through from grip and control actions on agency, etc., that really are making a difference, and will also be enhancing, improving into 24/5. But besides that, I wasn't going to add anything else, just to take questions from colleagues around the room. Thank you.
Not a question, but just a comment. I think the recognition of the system working together to that break-even budget for a second year in a row is something that we should document and just recognise all that hard work from all colleagues. And I just think it's really important to note.
Thank you, Nick. Yeah, I think it's a system achievement. So thank you to everyone involved, and thank you, Simon. It's a Neil. Yeah.
I just say, I welcome that, and I welcome the hard work that goes on. And I think I don't know quite the right phrase for it, but it's an important, with the efforts being made in the current climate, with all the things that we've heard about budgets and uplifts and finance, that it is actually a good thing that we are talking about pushing quality and safety to the forefront in the next year, 24-25. To ensure that during this difficult time we maintain such an approach as a system.
Thank you, Neil. Yeah, it's a good place to be. That it's a brief update, Simon, and I think we're coming into this at this March ICB really well aligned, and it's an improvement on last year as well. So thank you. Great. We will move on then to modern slavery statement from. Okay. No, can't do that one either. We'll come back to that one as well when Kate returns. Just items for information. I have the Making Care Closer to Home a Reality that was in your pack from the King's Fund report. Is there any discussion needed or questions regarding this paper? Debbie.
So, as Chief Exec of a mental health and community provider, I'd just like to commend this report to colleagues because I think it makes some really important points about the importance of primary care. So picking up on Stuart and Nick's interventions earlier about channel shift impacting on primary care, it outlines the importance of community services and how, in general terms, the range of community services are not often well understood. So I know as a board we're committed to doing more in that space, but also it commends the opportunities for partnership working with the VCSE. So I think this is a really helpful contextual report, not only just for our joint forward plan, but for some of the transformation ambitions that I know we're looking to for 24-25.
Thank you, Debbie. Sure.
Yeah, I agree. It's good to see. Frustrating, but and equally challenging, as well as really good to see. It will also next year. Regional priorities are community support, community services, whatever that looks like. That and obviously that's expanding, and we've talked about virtual wards, etc. So it will be front and centre of the discussions that we have, and I think it's helpful to have the report as much as a challenge. I think there's also something, going back to Carolyn's point about all the good work that is going on in Cornwall that's starting to demonstrate some of that shift. How do you actually measure the impact of that? Because it's really, oh gosh, I mean, I've been in community services from the regional perspective for a while. It's really hard to get the data to show the impact. And I think there's some work to be done, and I don't know how, maybe thinking about partner organisations that could help the system really demonstrate that impact. Yeah, you're already probably on it. The other thing is Chris Whitty has also just produced a really interesting report which talks about, and again it's reflected about ageing well, not necessarily living longer, but actually living well into old age. And I think that again chimes with what community support infrastructure is needed. So that's really helpful.
Absolutely. Yeah.
Back on the data point, so I really welcome Rachel's comments about data, because it has often been said that it's really hard to measure mental health and community services because of poor data, and certainly our organisation was in that place 2 years ago. But the work that we've done to build much better data and use business intelligence tools to enable that means that we've now got transparency of all of our community waiting lists. And although we don't like what it's showing us, we're now in a position to be able to share that in the same way as acute trusts can, so that we can measure our 104 weeks, 52 weeks, and so on. So again, I think it's important for us to demonstrate that we're catching up on the acutes in terms of data reporting.
And for those of you who haven't, I second Rachel's comment on Chris Whitty's report is definitely worth a read around longevity and aging well being so important. So Neil and then Emma.
Southwest region and parts of it are very much in the forefront of that aging cohort. But it's just to say, in terms of that data collection, that ability to build an outcomes framework for community-based working around complex issues like frailty and mental health, there are so many touch points that people need that contribute to that success, that we do need to agree as a system that we may not be able to hold on to the claim that it was our bit that made the difference. It's a collective and a collaborative approach to the outcomes that we need. And we may need to have to just accept that we've all contributed to it, but it might be hard to demonstrate what was the actual main keynote in it, because there's lots of things that have got to come together to make it work, and we've got to understand that right at the beginning, or we'll get into a battle over who's made the difference with their bit of the work that we're going to do.
Yeah, thank you. Emma, and then Stuart and Nick online.
I was thinking about how we as a board actually come back and make this a reality for ourselves, because there's some really helpful recommendations in there that cover a whole range of different areas, including workforce and our commissioning and planning. So making sure that we don't just see this as an information item that we've all gone, this is really good, but actually we do come back and say, what are we going to do about those recommendations and make them real for our system? And I'd really echo Debbie's point. One of the things that came through really strongly for me was the focus that this board has on its performance reporting, and that being very focused on acute and emergency care. And actually, I think we've talked about this a number of times in board, but we do need to do a bigger piece of work to have a much more rounded view of what performance is like across the system. And picking up on Neil's point, we will need to be brave enough to not necessarily be able to attribute that to a single organisation or a single part of the system. And from a voluntary sector perspective, there are very limited resources in the sector to do a lot of that data capture, and we don't see any of our data in board reporting, which was another thing I was wanting to make sure that we've designed in over the course of the next year. But support around that from colleagues would be really welcome.
Stuart and then Nick.
So, you know, I think the report is excellent. I think it rings true with a lot of the other national reports that we've seen coming out of NHS Confed as well. And I also think actually we're really well placed in Cornwall to make this a reality with the right kind of levers and financial levers. So there's lots of work going on in our communities already. Emma will vouch for the strength of the voluntary and community sector. We're doing a piece of work in central Cornwall at the moment on integrated neighbourhood teams. We've talked about the strength in primary care that in terms of the efficiency that it already has in general practice. So I think the building blocks are there really to make this a reality. I mean, it just does need that sort of leap of faith. And I would just come back to that previous point that we talked about before. That we don't have years to make this happen. There is a real fragility potentially about to develop in general practice and primary care over the next year. And I think in order to make this King's Fund report a reality, we just really need to be cognizant of that in year.
Yeah, Nick's next, yeah.
Yeah, just to follow on from that point again, it's a tricky time to be a GP. There's no doubt about that. And thinking about what will happen in the next sort of 12 months, I really haven't got a future scope on that, so I don't know. I really hope everything's going to be all right, but honestly, I'm not sure. And you know, coming back to what was talked about before about the hubs that have been set up and looking for value for money for them, and looking at the overall number of appointments that they provide. if you look back to a working day for myself, and Neil will remember this, I'm sure, a duty day for me, and we're not a particularly busy practice by any stretch of the imagination, but I can be doing sort of 60 patient contacts in a day on a duty day, and that's, works out at 10 minutes per patient, 6 per hour every hour without a break, through from like 8 o'clock in the morning until 6:30 at night, and that's including home visits, telephone consultations, and face-to-face as well. Now that's no one can say that that's sustainable, and part of the model that these hubs were set up on was not just to prevent footfall from into sort of secondary care, but it was also to provide sustainability for general practice, and we shouldn't lose sight of that when we're sort of counting the coppers and looking at what provides value for money, because without a sustainable general practice, we have no health system in Cornwall, and we're all interlinked, and without that part of the puzzle, then we're all completely stuffed. And so my plea to you is when we're looking at the hubs, they were set up at very short order. They're not set up in the way we would have wanted them to be, but they're as good as they can be in the time that they were set up. Now what we need to do is look going forwards and how we can maintain them, sustain them, and turn them into something that will truly be transformational for general practice in Cornwall.
Thank you, Kate.
So I think the challenge for us is really tricky, isn't it? Because we need to change. So the size and shape of how care is accessed in our county largely doesn't meet the needs of our residents. It doesn't focus on prevention and anticipatory care. It's about almost there's a little magnet that pulls people into not just RCHD but to bedded solutions. And we know that we spend a lot of money on that care that is not always meeting people's needs and isn't always the greatest place to work in. So for this next year, there are 6 priorities that were being set nationally that we'll talk about later, but they are desperately, desperately transactional and are about the front door of hospitals or treatment profiles. So the 4-hour standard in ED, the CAT2 ambulance response, faster diagnosis in cancer, 62-day recovery for the cancer pathway, and then 65 weeks for elective and 78 weeks for elective. And they are the things that we will broadly be measured on in terms of how we deliver. Now, I happen to think all of those are fairly great standards too, because they are in the NHS constitution, and we promised our people that they would be able to access care in that way. But at the same time, we have to change the paradigm through which care is delivered, and that's your point, Nick, around the building blocks of community services. A wise man said to me a long time ago around this sort of thing, you never know whose success has driven it, but the collective rosy glow we should all bathe in, that it'll only be if all the bits come together and that magic of teams working. So I think the point around this piece of work is well made. Maybe there are 2 things we have to hold ourselves to account for this year. One is delivering the things that we will be measured against, financial balance, and delivering on the transactional targets that we have to. The second is, and this is much more about where people live than the aggregate Cornwall level, how we're making a change in the places. We can use PCNs as the place, or neighbourhoods as the place, or ICAs at the place, but how we aggregate up what we're doing across the whole sector and be able to reflect that back. So we'll take this offline and work out how we can routinely report on that. But I'd like a flavour of it as well as the numbers. So Kelvin Yates from Chaos, from where? Age UK. Every Friday he sends out this is what we've done in the last week, and let me tell you a story about who we've helped. And I have to say, every Friday when I'm usually feeling a bit desperate, it makes me happy. Great stuff is happening in this county that results in better lives for people that we serve. So it's how we do that at scale. So we'll take that away. But we won't. This report will be a guiding light, not an information item.
Steve,
I think that's really helpful, Kate. It did make me think a little bit about the penultimate bullet point in the summary, which is about national bodies should give integrated care boards more trust and more devolved decision making. I don't know whether we've got a clear ask of the kind of national position. But I think in a number of these areas, we're already leading the way in some respects. And if we're not now, we've got the potential to do. And whether there's a bit of work for us to do to give some advice nationally on if there are obstacles from a delegated position, can we give some advice? Can we give a recommendation?
We had a really interesting discussion yesterday with Matt Nelligan from the national team around the operating model for the NHS. And written all the way through that is the delegation that we've got for local decision making. Now, I don't feel fettered in our system. So there was lots of discussion about whether foundation trusts were helpful or not, and could we get partners around the table and did they really mean it? And I genuinely don't feel fettered in our system. I do think that we are trying to do our best to achieve an end which makes life better for the people we serve. I don't feel fettered by my region. So I said that yesterday, and I said I think I'm sucking up a bit, but I don't. And if there are issues that we need to share with our region, it's a positive response that we get. So I think if we want to do things and we've got a good way of showing it, I think there'll be lots of flexibility. That was shut up, Kate.
Yeah. No, thank you for the intervention, but I think we are some way behind, and this was not a discussion agenda, but I think it's been really rich and helpful. And I particularly note, I think, Emma's points around how do we take this forward and think about doing more than a discussion, but actually integrate it into what we're doing. And also your point also on data from the voluntary sector. We're going to loop back now, Kate and Leighton are back to the integrated performance report. So Leighton, you're going to lead off.
You.
Yeah.
So I'm going to take it as read for these papers and be time critical around the key factors to draw out of this. I think also just a bit of reflection from myself, and in no way criticism from previous authors, but we are going to spend the next 2 months to bring a new review of the IPR to really draw out the constitutional standards and be clear of where our performance is and the actions underway to deliver that. So I feel it's slightly it could be crisper. So that will be coming in the next 2 months in relation to the visibility. As we know, the constitutional standards remain incredibly stretched. So the IPR that's a part of this paper is from January's position, so recognising they are somewhat out of date, but 2 of those were delivered around 4 hours and the faster diagnostics. That said, there's been some improvements, and we must remember those aspects, but there's also some considerable risks. So just around the UEC aspects, 4 hours did take the dip in December that we saw and recovered to 76.3% in January. We are slightly behind, as Steve's already alluded, the national drive to deliver 76. That's a real strong drive, and there's a real commitment in the system to deliver that. And we are incredibly close now to doing that, so it's maintaining it for the year. So thank you for the collective aspects on that. But I think it's really important to recognise the volume of patients who are spending way longer than 4 hours in the emergency departments, and even into the day, 2 days plus, and there are some significant numbers. So while 4 hours is important, we mustn't forget the aspect of 12. Cat2 response time still remains over an hour, but again an improving position, and that's partly thanks to the additional workforce that SWASTA provided, particularly in out of hours times, but also the dedication to drive and release our ambulances to focus on those patients still in need in the community. And as I've already alluded this morning, we still have a significant number of non-criteria to reside patients who are occupying acute and community beds who would be better served their care delivered in onward settings. From a planned care perspective, so there's been some development. So our waiting list size has reduced. So it's got to the lowest stage it has since July 2022. It's still double what it was pre-pandemic. So just to recognise it's the size of that change, but it is improving. The 78-week position is, I think, our biggest risk in relation to where we are with electives, recognising the drive to zero. So our reported position in December was 378. That's a bit of an increase in where we were in November, and we think that's driven from a bit of service delivery, festive period / industrial action. This does align completely with one speciality of trauma and orthopaedics. There is a plan in place. There is a there is a proposal of how we deliver that, and part of that's through additional sessions internally and focus on RCHT, and also utilisation of other providers locally, which has been 500 patients so far. Not all around 78, but 500 TNO patients moved on. So there is a trajectory for delivery, but we must state that's incredibly volatile in relation to progressing. And the same in relation to our 65 weeks, again, there's a trajectory to deliver there, but there are some aspects of risk in delivering again, and it is focused around that single specialty. Cancer faster diagnostics, like I said, has been achieved, and so effective progressions also on the 65 days for cancer. They are fundamentally, the only other aspect just to raise around elective. So as you know, the system is in a tier 2 position for elective management. That's becoming increasingly positive. And if we look at a scale of moving from 2 to 3 as opposed to 2 to 1, we are very much at the scale of moving from 2 to 3 in relation to our tiering position for elective. So it is recognised from a regional perspective and therefore nationally the progressions that's been made on our RCT position. There's no other aspects I really want to raise, but open to questions. Thank you.
Debbie.
I'm grateful for the reference to delayed discharges in community and acute, but we're also struggling with delayed discharges in mental health. So we've currently got 20 delayed discharges, and 5 of those are over 100 days. So if you think of people being detained under the Mental Health Act, that's actually something that we do need to give much more focus to. And I know it's one of our soft criteria to reduce the number of out-of-area placements, but if you weigh off 5 out-of-area placements against 20 delayed discharges, actually as a system, we're doing incredibly well with the bed stock that we've got. So hence my interventions earlier around support for housing options, because this really is impacting on some of our most vulnerable. And if we're driving up parity of esteem, it would be really helpful to have greater sight of this in future iterations of the report. But thank you for the updates you have given, Leighton.
Steve?
Leighton, really welcome the report. Very, very helpful, very clear. So thank you for all of the work in that. We've touched on the 76% ED national requirement a couple of times during this meeting, and from what I see, the entire system is focused on doing everything it can to address that. And as you've indicated, we are very close to, but below that performance month to date. We have provided significant support to UHP as a system, whether that be through CFT prioritising community beds and therefore they're not available to RCHT discharges, or through ambulance diverts and other aspects. There'll be a primary care component to that, which firstly I think is the right thing to do given the critical incident that UHP have been in recently and the wider pressures that they've been experiencing. But it's not inconceivable, Leighton, that we could just miss the target of 76% despite our best efforts. And it's possible we could be close enough that might not have been the case without that support to UHP. UHP do provide us support at times as a system when RCHT is in critical incident, and I absolutely recognise that. And again, that's the right thing to do. But I recognise that for the significant periods of this month, we have been in some form providing support. So I just wonder if there's any way of clarifying that the ED performance impact on that, not to distract us from the focus that we need to do everything we possibly can to address that, but I could see that the margins could be so tight that we may not quite get to the 76%.
So Steve, you're absolutely right, and the success of a delivery for an emergency department or an MIU is twofold. One, having a designated stream to manage those people who were not admitted and delivering those patients in a timely 4-hour process. That is reliant, therefore, having the flow into the hospital, so the minor aspect of an emergency department doesn't become full of people needing beds, and I know that's a daily occurrence you battle with. So flow is the pivotal aspect of the delivery of 4 hours and very much recognised. hence why you'll appreciate our constant discussions about our current 200 non-criteria to reside patients. So the aspect just around balancing the juggle of our valuable capacity that we have against the RCHT facing or UHP facing is a daily review that we do. You'll be aware of the change we've made this week in funding the beds at Mount Gould for Devon, so that gives additional support to Cornish patients in UHP, which therefore has a positive balance to utilise some of the capacity more for RCHT facing patients. So we do, just to give you the assurance, make that view on a daily basis and balance that risk with regional oversight as well to help guide that. So I think it's fair to say, Kate, you're involved in those conversations most days, aren't you?
I think we can look at the numbers of ambulances that, because it's the divert, isn't it, that we take on from UHP. My understanding is we call it, but I'm not sure that many ambulances get diverted. Where I think there might be more of an issue and less of an ability to track it is when the communications go out. And I live in Lostwithiel, and I could go to Derriford or I could go to Trelisk, and if I heard that one place was full, then I'd go to another. So I don't know how we would map that through. But you make a good point around pressure on RCHT, but also something that I'm proud of, that UHP and RCHT are working together for a population response, and I'm not sure we always see that in our system. So it's something that I think we should be applauding both of you for.
And if I could extend that to CFT, I think the dynamic way in which CFT colleagues are able to flex or prioritise the limited daily number of community beds to respond to that, I think is also a significant part of that.
So we have taken a decision on gold today that is unusual for us, but I think similar for other places in the same place that we are, where we have people waiting for long periods of time for services that may not be available in their local areas. We've asked for the numbers to be quantified so we can look at temporary residential care with active case management. So, to use Tamsin's words, the Chief Operating Officer from CFT, people don't lose their place in the queue, but it allows us to maximise the resources we've got to be able to make sure that the whole of our flow works a bit better. So we'll be talking to our buyers and brokers as soon as we've got that list about how we could make a difference. And I don't know, Debbie, whether any of that would apply to people who've had been detained on a section and are waiting somewhere for supported housing, whether there could be any interim step. I know it's not perfect, but an interim step that allows them to move on, but also for that bed to be made available for people locally who are needing to use it. So we could look at that as well.
Yes, Rachel.
I think just to acknowledge that as a region, we're actually only at 71.5%. So there's a bit about collectively how everybody's putting together in the region to drive that. And so I would also acknowledge that the work across Devon and Cornwall is exactly what we want when we talk about the South West Way, don't we? Which is we're all in it together, and every system, north and south, is struggling, and there's golf calls all over the place. But actually, where Cornwall is at the moment is in a very good place comparatively.
That's great. Okay, thank you everyone, and thanks for the work on this, Leighton. Moving on to modern slavery statement, and we're jumping around just to fill the agenda items that we skipped. I think that's still with you, Leighton, because it would be Susan otherwise. Oh, Chris is doing it. Okay.
So just give me, find my spot. So this is really a statutory requirement that we have to give a position on modern slavery. So this is a statement for us to, as a board, to endorse and approve.
Yeah.
The point I would make about this is it's not just what we do as a corporate. This applies and make sure we have to look into what happens with our providers, as well as not just from a health perspective, but anything that we may purchase as well, that we have to look for and assure ourselves that that process is not subject to slavery. And of course, you know, they have been aspects of this, so that's why this statement's really important. It needs to go a lot further than just the ICB corporate level.
It's certainly been through FPCC as well. I assume other committees. Yeah. So in terms of decision here, sorry, give me a second to pull it up. Or Chris, can you just draw attention to, is this an endorsement or?
So the board's asked to approve the contents of the statement.
And our intention to audit ourselves against compliance with it.
Right.
So I think that's important.
We have, sorry, yeah, Rachel.
Support the statement, I think, is just a comment around the whole system work that Safe for Cornwall does, and the ICB is a partner member of that partnership, which is Devon and Cornwall Police and a whole range of other partners, the Cornwall Council, ours at Scilly, but that they have a priority around modern slavery and a whole range of objectives within it. So noting that the statement is for the ICB, but it'd be nice to sort of in the notes to reference that the system work, draws and coordinates work across all partners, and that's always there for partners and providers to draw on their expertise as well.
Mary, did you want to come in?
Yeah, can you share the did you say audit? You're auditing.
No, so we haven't. So we will. We've had a discussion about this. We can have a statement. But how do we know that we are using that statement to make a difference?
Yeah, we can share and use the same thing, because we're having people knocking on the doors every day who are stranded, because they've been subject to human trafficking for financial exploitation. And we've got this massive problem that we've got a shortage of care workers. We've got these care workers who would like to work for us, but we can't get the undefined costs to take them on.
Just to be clear, the audit hasn't been done. It's
I
going
got
to
that
be.
just now, yeah, thank you.
Yeah. Myri and then Steve or Steve.
I think Steve was first.
Okay.
Well, just briefly, from an NHS provider's perspective, CFT, RCHT, SWAST, UHP, etc., the equivalent mechanisms are in place to drive this challenge forward in those organisations. It's really helpful, Rachel, to hear about the wider context, because one of my questions would have been, Chris, the comment about how we consider supply chains in our non-healthcare services, but I think Rachel's answer was kind of really helpfully addressing that as well.
I think, Mary, you may have partly covered this, but I did wonder in that first paragraph of our proposed content on the last line, whether we should refer to financial security, because we talk about what we say, an underlying personal identity and sense of self, but there's no financial security either, and maybe it's obvious as part of the rest of it, but I just wonder if we should draw attention to it. Chris may have a view, but I thought if we put financial security after personal identity, that might make it better.
Okay. Chris, do you want to come back on that?
Mary's comment.
Yeah. So do we want to? So
the question is, do we therefore amend the statement to include financial security, and your view as to whether that would be good to do?
Would be happy to do that. That's
Unless you think it's covered elsewhere, but because I haven't looked in detail, but I think it's a very powerful statement. We could sign up to.
So, Chris, could you take that away, discuss it with Susan?
Yeah.
And then for the next board, Mary will give formal feedback on the inclusion.
It does refer to fraud, if that might fall into that.
I'll take away. Look at reward, and then we can bring it back.
If we need to amend and approve again, we'll table this quickly for the next one, or possibly on the March 20th one. Thank you. Just moving on to last items before lunch. Forward plan. So not the joint forward plan, the forward plan. We've got to think about language. I think we've got can be confusing. I'm not proposing to make any radical changes till John gets back in terms of the forward plan. But any comments on that forward plan? Any issues or things that need to be bumped? I mean, the principle certainly that the committee chairs are taking is that we've got a cascade from this forward plan into committee agendas. So I'm particularly looking at committee chairs to make sure that things that are coming to the board in the forward plan really need to be discussed by the relevant committee, depending on the agenda item beforehand. So do think about the so what when you see any of the agenda items. Just focusing on the immediate priority of the April board meeting. We have only standing agenda items I can see at the moment. and nothing there looks radically out of place. We did do some tidying up last month, I know that, so that seems to have gone into effect with this as well. Any comments, questions, challenges on the fort? Yes, Steve.
Just a quick one for me, and it's regarding the winter plan, whether with the challenges we have of finalising the 24-25 preparation, whether it's helpful to have that standing update in April, whether it might be useful to have a winter plan review in May. I'm very happy for it to be on the agenda for April, but if it creates a bit more time and capacity to move it to May as a formal debrief.
Yeah.
Right, I do.
I think there's broad support for that. Debbie.
Thank you. So for the April 24 meeting, there's a deep dive on learning disabilities and autism. So I'd originally proposed that I would bring an overview of the new capital developments that are happening in the Southwest region, and board had asked for a broader LD review. However, both the commissioners that I would be working on that are no longer available to me. So I'm slightly caught with this timing for that item now, Sanj, because of some changes in personnel.
Tim Francis, and I think he'd be happy to come back for that board. So if you're happy to do it, then I can speak to Tim and ask him to make contact with you.
Okay, well, I'll see what we can pull together. I mean, I can still offer the overview of the new regional facilities, but the wider piece would need to be very much a joint piece of work.
But Tim's, I don't know how many years Tim's worked in Cornwall, but it's quite a long time, and he's been snaffled by NHS England to go to the region. So I think he would quite like to come and say, and this is the work we've done. So I'll speak to him, and then I'll ask him to speak to you.
Oh, well, it would be wonderful if we could get him to almost showcase as a bit of a swan song.
Indeed,
then, couldn't it,
yeah,
Kate?
yeah.
Well, I just want to comment on the April meeting. So in terms of approval of a 24/5 budget, we won't be in a position to do that in April. So because we'll have to consider putting an extraordinary board meeting at the end of April for the May submission. And so I think there's a distinction between what I would want to do is agree a Q1 plan that we're all going to work with, because we need to for the purposes of money and operation performance, but that it would just be an update on the overall 24/5 plan brought to that meeting. And we won't be in a position to approve an overall budget. That's because we'd be required to be working towards the May submission deadline.
So it'll be work in progress in April. But I think Steve's quite right in terms of the time that we might need on the agenda.
Yeah, indeed.
There may be some choices that the board needs to make as we go through.
Okay, I think it's better we schedule that, even if we don't need it, being the principle at the end of April, early on around people's availability.
I think it is worth noting we'll have to consider putting in an extraordinary board meeting for signing off a May submission.
I'd support that if that's necessary, Sam. I was just trying to refresh my memory on when the submission is due. We do have the ICB board meeting on the 9th of May. Is that too early? Or could we use the existing 9th of May meeting?
We may be able to, I'm just getting the view that it might be really early in May, sort of straight after the bank holiday, but we'll wait and see what the timing turns out.
Can you have a look at the timing,
Yeah,
and
indeed.
better we put the meeting in and not need it than try to schedule it.
I'm assuming it'd come out with the guidance. We haven't got the guidance.
Yeah, okay. Jodie, yeah.
Just a small point, just the Health Watch annual report is scheduled for June, but it's not published until the 30th of June, so if that could just be moved to July.
Okay, shall we bump that to July? That's easy.
It has to be submitted to Department of Health on the 30th of June. So.
Okay, but July's would be safe. Yeah. Great. Okay. Great. No other comments, I think, on the joint forward, on the forward plan. Any questions from members of the public? No. Great. Just before we close, just a couple of things to note. We are saying farewell to Anne James from UHP as CEO, as Steve mentioned. So we pass on her thanks as a colleague and note that for the minutes. And we are also saying farewell at her last board meeting to one of our own, Carolyn. This will be her last ICB before she retires. So I know John would also want me to pass on thanks from all of us as non-exec colleagues, but also the full board for all your years of service and support and tenacity.
All my years of service. Wow, not that many.
And wishing you a really happy and peaceful retirement, and hopefully you'll stay in touch with colleagues across the system, or not, depending.
Kate has her way.
She will be. You know that phrase, retire and return. So we do need to thank Carolyn, because a lot of the pulling all of us together and getting us in a place where the ICB became live was largely down to her good officers. So we will miss you a lot, and thank you very much.
Thank you.
Change your mind now. Well, Kate's trying to.
All right. Thank you, everyone. So we're going to close part one. Hopefully nothing missed off, and we'll reconvene at 1:30 for part two. So saying farewell to members of the public and press. Thank you.